Hi, good afternoon, ladies and gentlemen. A very warm welcome to you for Remarkable Rapid Revision 2.0 in Ophthalmology. A very warm welcome to you from Hyderabad. It's a very warm evening here. And so again, good evening. Vanakkam, Namaskar, Sasriyakal, Adab, Privyat, and Niha to all of you across the world. So you might ask, what is this remarkable rapid revision about? And remarkable is about the fact that a normally 40-hour ophthalmology lecture we can compress in 7 to 8 hours. Okay, so we are going to have 7 to 8 hours of high density MCQs, high quality MCQs, which you can get up from here, and only from Dr. Bhanu Prakash's YouTube channel. So I hope you're all keyed up. So without wasting further time, we're going to start this, and your questions are welcome. Remember, it's live, so if you write questions to me, I will get back to you as soon as I can. Okay. So very well, this happens to be my photo, the first slide. Some of you are not able to recognize this because I keep getting handsomer, younger and handsomer every day. So that maybe some of you cannot recognize from this photograph, isn't it? Very well. So this is, ladies and gentlemen, Ophthalmology live on Dr. Bhanu Prakash YouTube channel. Remember, normally we expect about, in ophthalmology, we expect about 15 to 30 MCQs. Not anything. 15 is the bare minimum. So this is what we expect. But last time there were almost 23 questions of ophthalmology. Now you cannot predict this. Okay? I must tell you at the beginning that any time the examiners want to make a more difficult paper, question paper, they will include more questions of ophthalmology. As you all know, it's the single most difficult subject out of all 19 subjects. So if you want to make life easier for you, I suggest that we start studying ophthalmology. Right? So here it is. You can see these hypnotic eyes, these mesmerizing eyes, the most famous eyes of the 20th century. And here we go. I'm going to start with embryology, because embryology, even though it's a part of anatomy, remember embryology, the first thing to remember in ophthalmology is that out of the three primordial germ layers, ectoderm, endoderm, and mesoderm, we do not have any derivatives. We do not have any derivatives from endoderm. So that makes life easier. We have from ectoderm, mesoderm, and neural crest, okay, of which the ectoderm is further divided into surface ectoderm and neuroectoderm. Okay? And remember that always, for some reason which I'm not able to understand, the question is always from surface ectoderm. Okay? We don't have questions from mesoderm so much or neural crest at all. We're going to focus on the most important. Remember, it's a short, concise, it is a rapid revision, so it will be done very fast. So of the ectoderm derivatives, we divide into surface and neuroectoderm. Let's look at the derivatives of surface ectoderm, which are usually the most commonly asked questions. And here we memorize it by this simple mnemonic called level. Level, because you're working on a surface. Remember, surface means level surface. You're walking on level surface. And that stands for LEVL, which is L for lens, E for epithelium of all the structures of the eye except the ciliary body and the iris, V for vitreous, and L for lacrimal apparatus. Okay, so LEVL. Remember, most of the time we keep getting questions from the lens. It's derived from which? And you will say surface ectoderm. And the next one is the neuroectoderm. Okay, I told you the most questions are asked from the ectoderm. So we divide into surface and neuro. And neuroectoderm, you remind is yourself by rows. Neuroectoderm, rows, and R for the retina, because remember it's neuro, so retina and optic nerve, RO. S for the sphincter and the dilated pupillary muscles of the iris. Okay, remember the pupils constrict and dilate. So the muscles which dilate the pupil are dilator pupillae, muscles constrict the pupil is sphincter pupillae. And E is the epithelium of the iris and ciliary. But remember, the epithelium which is missing from this previous, except iris and ciliary, this epithelium makes its appearance on the neuroectoderm. Okay, so rows. So this is about all the ectodermal questions you get. And we are not going to talk about then the mesoderm structures and the neural crest, because those are not really asked. So this is enough about a bit of the embryology that you need to know. Then we start with anatomy of the orbit. We're going to do orbit and oculoplasty. In the orbit, what are the most important MCQs of the orbit? Remember the famous rule of 7. Okay, 7 bones, 7 muscles, 7 nerves, and 7 contains 7 suspensions of the eyeball. Okay, suspend by 7 attachments. The first question is, what is the volume of the orbit? Remember, the volume, you have to memorize this. Certain figures you have to memorize. I always mention that. And we have a slide where we will give you the most basic measurements. 30 ml is the volume of the orbit, but the volume of the eyeball is only a measly 6 ml. Remember, a teaspoonful is only 5 ml, and the eyeball is only slightly bigger than a teaspoonful, which is 6 ml. And it's suspended by the 7 attachments of the 6 muscles and 1 optic nerve. Now, of the 4 walls of the orbit, you have a superior, inferior, medial, and lateral. And if you look at the diagram here, these are walls, and they're just walls, nothing else, as bare as a prison cell or a monk's monastery. And of these 4 walls, superior, inferior, medial, and lateral, remember the thinnest wall is the medial wall. Okay? The thinnest wall is the medial wall. Okay? Always the medial wall is thinnest. And those who study anatomy, you know that that is because of the lamina papyracea. Okay? The lamina papyracea, which is the wall of the sphenoid sinus, I beg your pardon, the ethmoid sinus. This is the thinnest wall of the orbit, the weakest point of the entire orbit. Okay? So this is the medial wall, the thinnest. But however, kindly remember, the most commonly fractured wall of the orbit is the inferior wall. Okay? It's not the medial wall, it's the inferior wall, which is the floor. You see it in the diagram. Why is that? The reason is simple. As I've talked to you in many of my lectures, is the inferior wall is thicker, but yet it is the most commonly fractured wall, because just under the inferior wall lies the maxillary sinus. The maxillary sinus, and the maxillary sinus is completely hollow and cavernous. It cannot support the inferior wall or the floor. So that's why it fractures. But the medial wall, despite being thinnest, still is supported by the air holes, the holes or the air sinuses of the ethmoid sinus. You know, the ethmoid sinus is full of air. It's the honeycomb structure. And this honeycomb structure, which looks like this, any structure which is full of air cells as the ethmoid sinuses is bound to support the overlying wall, which happens to be the medial wall. So medial wall, despite being thinner, does not fracture so often as the inferior wall, which despite being thicker, fractures more because there's nothing to support the inferior wall or the floor. Okay, so remember, anatomy is important. Anatomy is destiny, as Sigmund Freud said. Okay, very well. Then what about the salient points of the eyeball, which you need to know? I'm getting some of these for your complaint about the audio. Is the audio not coming out too well? Okay. Please check the audio. Is it better now? Just tell me. Is the audio okay? Fine. So we're asking the technician friends to adjust the audio. And let's hope now audio is better. Very well. So now let's look at the 3 concentric layers. You know that the eyeball is composed of 3 concentric layers, one below the other, like a matrushka doll in Russian and Ukraine. No, we have this matrushka doll-like structures, the outermost layer, the middle layer, and the inner layer. And the outermost layer is the cornea sclera, which is the tough fibrous layer which protects the eyeball. The middle layer is a vascular layer, where the blood vessels are, which is the iris, ciliary body, and the choroid, which is called the uvea, which means grapes. And the innermost layer is the retina. Innermost layer of the is the retina, which is the nervous layer. So we have the outer fibrous, the middle vascular, and the inner sensory layer or the neural layer. Okay, and then this is the 3 layers to begin with. Then remember, the MCQs often ask that all the structures of the eye have their own blood supply except 2. And you remember the 2 avascular structures, which is the cornea and the lens. Please remember that they don't have their own blood supply at all. No, kindly keep checking the things. And the audio calls constantly. We are monitoring the audio. Don't worry, I'm looking at your responses. And the total refractive power of the eye is a massive plus 60 diopters. Okay, plus 60 diopters. Remember, we write it plus. Why? Because in ophthalmology, anything that converges rays of light like this, any lens converges, we call it plus. Anything that diverges like this, we call it minus. Since the rays converge onto the fovea, we call it plus. Okay, and 60 diopters, of which 43 diopters contribute by the cornea, which is 70% of the power, and lens contributes 19 diopters, which is 30% of the power. Okay, you might argue 43 plus 19 should actually be 62, but they are not in contact with each other. You see, the cornea and the lens are subset to each other. So since they are not in contact, so they will not be exact summation. Okay, it's not really 62; it is closer to 60. And then this is the slide I was telling you. Is that it is the slide which gives you all the important measurements which you have to memorize here. Look at that. Here we meet The original volume, I said 30 ml, but the eyeball volume is 6 ml. You have to memorize these numbers, kindly remember, okay? These are important numbers in ophthalmology. Axial length of the eyeball, which is the from center of the cornea to the center of the retina, gives you the anteroposterior diameter. This is 24 millimeter. Antechamber depth, which is from the center of the cornea to the center of the iris. This is average is 3 mm. And the critical angle, now this is a new question. Remember, of late in the last 2 years, this question has been asked, what is the critical angle for total internal reflection from tear? See, what does this means is that why we can't see the angle, is not. When we want to see the angle of the eye, this cannot be seen because you see, this is the iris, this is the angle. The rays of the eye, the light that travel from the angle, they get reflected from the cornea like this and goes back into the anterior chamber. So that's why you cannot see the angle. So this critical angle has to be more than 46 degrees. You have to remember this, 46 is critical angle. So when we put a gonioscope on the eye, it increases the angle by more than 46, and then we can see, as you can see, these rays are no longer coming inward, then they go out like that and you can see the angle. So kindly remember, critical angle is 46. This is a memory based question. We cannot help it. You have to memorize this. Average corneal thickness is about 540 microns. Most of us have around 540. Some of you have thinner, some of us have thicker corneas. Ascorbate is the highest amount, remember, in the anti-aqueous humor. The one component that is higher compared to the blood is vitamin C or ascorbic acid or ascorbate, which is almost 30 times higher compared to, this is in the aqueous. Remember, this is not a vitreous, it is a misprint here, it is an aqueous. The 30 times higher in the aqueous. This is one component that is very high in the aqueous compared to that of blood. Aqueous formation again is important to memorize, 2.5 microliters every minute. Okay? 2.5 microliters every minute. This is the, you have to memorize this particular figure. And remember, this is the formation of aqueous every minute, and it remains all the time the same thing, except at night when you're sleeping, where it comes down by 50%. Okay? Otherwise, the volume of the aqueous production is the same. Then, the fovea diameter, the optic diameter, you have to remember this, is 1.5 millimeter. We often this call this optic disc diameter as ODD. So kindly remember, this is 1.5 millimeter. So sometimes we can ask you, how much is 2 disc diameters? You'll have to calculate 1.5 into 2 is 3 millimeters, right? So if you write 2DD, you must write 3 millimeters. If they say 3DD, it becomes 4.5. So that is then, and how much is the visual field? Remember, monocular means for one eye visual field. Remember these limits, superior, inferior, nasal temperature. Remember, superior field is the shortest, 60 degree. Then is the nasal, which is 60 degree. Then is inferior, which is 70 degree. And then is widest is temporal, which is 100 degrees. Okay, so remember the shortest is the superior and the nasal. Why? Because of the forehead and the nose blocking the field. Okay, so these are two shortest, but however, if asked which of them is the shortest, it becomes superior. And temporal is the widest because there is no obstruction of the temporal rim. So temporal, there is no obstruction here, so temporal field is the widest. But also remember, temporal rim is also the most unprotected because there is nothing blocking here. Often injuries come from the temporal side of the socket and damage the eyeball. Okay, so everything has a flip side. You may have a wider field of vision temporal, but it's more susceptible to outside danger, isn't it? So fields are done. And how much is high myopia? Remember myopia, anybody more than -6. So those of you, my friends, who are wearing more than -6, which is -7, 8, 9, 10, 20, whatever, you are high myopes. Remember, this is called as high myopia. More than -6 is high myopia, which puts you at slightly risk of developing retinal detachments. Okay, anything more than -6 is high myopia. Intraocular pressure is between 10 to 21 millimeters of mercury. Now, one question I am getting this again and again is, there is this rapid enough to pass FMGE 26? Well, friends, I really cannot predict that because I'm not being God. I cannot say this is enough or not. But yes, it is, most of the time it's enough because, see, after all, it's a 6, 7, 8 hours maximum thing. Now, of course, it cannot cover 100% of all the MCQs that is possible to ask. But yes, I think, and I have done my best to, it should cover almost 80 to 90% of your questions. Okay, that's the best answer I can give you because I cannot predict the questions that can come, not being God. Okay, so 10 to 21 millimeters of mercury, remember, is the variation of intraocular pressure, but the average pressure is 16 millimeters. Most of us intraocular pressure around 16 millimeters. So if you check my pressure or yours right now, will be around 15 to 16. This keeps varying all the time, but if it goes beyond 21, it's diagnosed as glaucoma. Then how do I inject intravitreally? Remember, intravitreally, you want to inject an injection inside the vitreous cavity. Where will you go through? Not through the nose or the forehead, but through one particular structure of the eye, which is called the pars plana, is not? So this is called pars plana. Intravitreal injection is through the pars plana, because this is the only structure that is safe enough for us to inject. And the site of pars plana, remember, there are two different questions. The site of pars plana, as you've seen this picture, is approximately between 3.5 to 4 millimeters from the limbus. Okay, so remember, not through the limbus. You enter through the limbus into the anterior chamber. Okay, you enter through limbus into the anterior chamber, but you enter into the vitreous cavity via the pars plana, which we measure by using calipers around 3.5 millimeters from the limbus. Okay, so kindly remember, through the pars plana is vitreous, through the limbus is anterior chamber aqueous. So after having taught those, gone over the basic ophthalmic measurements, now we go to the next thing, which is the orbital adnexa, and orbital adnexa. What about this? So let's talk about the Graves' disease, which is thyroid disease and thyroid eye disease. So let's look at the most common question of thyroid. Remember, the most common cause of proptosis, you can see the proptosis, also called as exophthalmos, is thyroid eye disease, also called as Graves' disease. Okay, remember, this is the most common cause of thyroid, which is much more common in ladies, almost 5 times higher than women compared to that of males. But please also remember, the most common presentation of thyroid, is not exophthalmos, it is actually lid retraction. Okay, so be careful. So it is when they ask you what is the commonest presentation of thyroid, you don't say proptosis or exophthalmos, you say lid retraction. Retraction means going back. Like you look at my lids, looking at you like this, the lids go back like that. Okay, so this gives you a very angry looking patient. The patient looks, he's staring at you like that, as he's very angry with you because the lid goes back. Okay, remember, this is the most common manifestation of thyroid eye disease. Okay, most common thyroid disease. But if the question is what is the commonest cause of proptosis or exophthalmos, that's become thyroid. So be careful not to be confused with the two questions. Then the next thing is the most common muscle get restricted in thyroid disease is the inferior rectus muscle. Okay, why does the muscle get restricted in thyroid? Because you see, in thyroid you have these mucopolysaccharides, MPS, which you have done biochemistry, and these mucopolysaccharides, they deposit on the muscle tissue, they damage the muscle tissue, and these muscle fibers, they cannot contract. So when they can't contract, so they cannot move the eye. It's not, the eyeball will not move simply because there's no contraction of the muscles. So when they can't move, so it causes restriction, and the restriction follows a certain order. Okay, certain order. This order is called IAMSL. It's easy to memorize. It stands for I am so lucky. Why am I so lucky? Because I have such wonderful students sitting here watching me, making fun of me. I am so lucky. But what it really means is I for inferior rectus, M for medial rectus, S for superior rectus, and L for lateral rectus. Remember, the first muscle to be restricted always is the inferior rectus, and then the medial rectus, and then the superior, and then the lateral. This stands for I am so lucky. It's a mnemonic to measure. Right. Then the next question is going to be a very famous sign, which is called a fusiform dilatation of muscle belly. See what happens? You know, normal the muscles, they look like this. This is the muscle belly, and this is the tendon, which attaches to the bone. So in thyroid, the mucopolysaccharides, they deposit on the muscle belly. Remember, when they deposit on the muscle belly, so the muscle belly becomes enlarged like this. Okay, this is called a fusiform. Fusiform means like a turnip. Okay, a spindle-shaped thing, spindle with the tapering ends, superior and inferior, and the centers there. So because it enlarges the size of the eyeball, so it pushes the eyeball out. There's no space in the orbit for the eyeball. That is why proptosis occurs in thyroid, because there's no space inside. The enlargement of the muscle belly. But also remember, the tendon is spared. Okay, the sparing of tendon is a very important sign. It'll only cause bulging or enlargement of the belly, muscle belly, not the tendon. Okay, and this because it is the sign. So you can pick it up in a CT scan. In a CT scan, you'll be able to see the enlarged muscle belly bulging like this with the thyroid, with the tendon completely spared. And this is called the Coke bottle sign, because as you can see, this is a Coca-Cola bottle. and does not look the enlarged muscle belly, and this is the tendon. Okay, so this is the Coke bottle sign, or also called the Coca-Cola bottle sign. Okay? You can see this is a very powerful sign, many times asked in NEET PG also and your MCQs also. Very well. The next question is on the orbit after having direct proptos. Next question is about the blowout fracture. We call it the blowout fracture. It happens to be a very powerful MCQ. Every time, each year, there is at least one MCQ on that. And it's called a blowout because there seems to explosion. It seems to blow out like that. And remember, the definition of blowout is that it is fracture of any of the walls of the orbit, superior, inferior, medial, lateral, but without including the rim. Remember the border of the wall, the rim is very powerful and cannot fracture. So in a blowout fracture, there is no fracture of the rims, but an isolated fracture of any of the walls. And we just talked about this. Remember, the inferior wall is the most commonly fractured, okay, or the floor of it. Why? We just talked about it because there is no support for the floor or the inferior wall. And the famous triad that you know, which you have to remember, ophthalmology is full of triads. Triads means three things. It's easy for us to remember these triads and apply them in the MCQ. So this is the famous DIE, okay. DIE, it stands for die, not that death, not death. We all have to die, of course, but not today, inshallah, not today. And for diplopia stands for DIE, which stands for diplopia, which is double vision. Infraorbital anesthesia, here on the inferior half, you will be completely anesthetic. Why is that? Because the nerve gets damaged. There's infraorbital nerve here, which gets damaged in fracture. So you cannot feel it. After the fracture, if you touch it, even with a pin or a lighted matchstick, you will not be able to feel it. It is completely anesthetic. Okay? This is called infraorbital anesthesia. And enophthalmos. Remember, enophthalmos, it goes in. Diabol goes in, which is called enophthalmos. It sinks inwards. It's exactly opposite to exophthalmos of thyroid. The famous triad, diplopia, infraorbital anesthesia, and the teardrops. And can you see the teardrops? It calls teardrop because this is the orbit, and as it fractures, the contents of the orbit, the herniate downwards like this into the maxillary sinus, which is the inferior. This is the famous inferior fracture, and this you can see in the diagram here, the CT scan, the teardrop sign, and this is the famous teardrop sign, which you love to ask in ENT also, which my friend Dr.G will be soon taking, and it is also seen in, we asked in radiology, we asked in ENT, anatomy, and ophthalmology. Remember the powerful teardrop sign. Okay, very well. What next? Then we come to tumors. Tumors are going to be a very important source of MCQs. And so remember, but here, before we go to tumors, I want to tell you something. Remember, when we do ophthalmic tumors, you have to remember whether they're asking it's orbit or is it eyeball. Remember, orbit is the bony cavity and the contents. The eyeball is different from the orbit. So be careful. Are they asking orbits? Are they asking the eyeball? Okay. Eyeball, if they ask, then the answer changes because we're talking about the soft tissue. If the orbit, we're going to talk about the contents of the orbit. Is it the orbit of the eyeball? Is it primary or secondary? Primary means a tumor of that particular structure. Secondary means it comes as metastasis from some other tissue. And third, is it an adult question or is it pediatrics? Remember, tumors differ from adults to children, so we have to be very careful. So here we are talking about orbits, so we are going to talk only about the orbit here. So let's look at the questions here. Now look at this. This comes to be the most common primary tumor of the orbit in children is a dermoid cyst. Remember, dermoid cyst is a benign tumor. This is the most common tumor of the orbit, primary tumor in children. But if they ask, remember, if they ask a most common primary malignant tumor of the orbit, remember, it's not dermoid cyst because dermoid is not malignant. The malignant would be rhabdomyosarcoma. So be careful what they're asking. Most common overall malignant tumor of the orbit in children is rhabdomyosarcoma. What about secondary tumors metastasizing? Remember, secondary tumors, they come from neuroblastomas, and neuroblastomas are tumors of the renal gland, and when they metastasize, this is the most common tumor to metastasize to the orbit of the child. And you can see the famous raccoon sign. Can you see that? This dark raccoon sign, this leads to a very famous raccoon sign because the child looks, eyes are dark like a raccoon. Okay, you've seen the raccoon's eyes, they are dark, filled with blood. So this darkening, this raccoon sign is the bleeding around the lids that are ecchymotic patches that are visible around the lid that you will see. And so remember that this could be a very dangerous cause of a neuroblastoma metastasizing to the pediatric orbit. Okay. Then the most common primary tumors of the adults are cavernous hemangiomas. Remember, these are cavernous hemangioma means that in adults, it is a tumor of the blood vessels of the orbit. Okay, so remember these are orbital questions. So this is a blood vessel and it's a tumor of the blood vessel of the orbit. Cavernous hemangiomas are benign tumors found mostly in females between 20 to 45 years of age, and they cause proptosis. They cause proptosis, pushing the eyeball. It's a benign tumor. What about malignant tumors? In malignant tumors, remember, this is the most common question asked to us these days. This is the most common malignant tumor, I beg your pardon, secondary tumors to the adult orbit is going to be metastasis from breast cancer. Remember, number one is breast cancer, followed by lungs and prostate. So overall, most common is breast cancer. Remember, this is the most common tumor of the females. Okay? And if they ask males, then you ask a lung cancer. So kindly remember, CA breast is the most common metastatic to the adult orbit. And a very powerful question is, remember, this breast cancer, particularly serous. Serous means heart. The serous breast cancers, kindly remember, cause enophthalmos. What is that? They push the eyeball in. Now that's surprising because you would expect the metastasis to push the eyeball out and cause proptosis. You would expect that. But no, it doesn't. It causes exactly the opposite. It causes fibrosis of the extraocular muscles and it pulls the eyeball in, which is causing enophthalmos. So be careful. We can ask this question. What is the most common tumor of the orbit in females? Okay. What is the most common secondary tumor of the orbit in females? Remember, it is CA breast metastasis, okay, which causes enophthalmos. Then we come to the next orbital structure, which is going to the ptosis. Ptosis, remember, is drooping of the upper lid. The ptosis, the P is silent. Remember, it's ptosis. And ptosis is drooping of the upper lid. Normal lid droops around. Remember, it covers 2 millimeters of the eyelid. It covers 2 millimeters of the eyelid. And so, if it's more than 2 millimeters, this is known as ptosis. It can be either congenital from birth onwards, or it may come after 1 year of age, which is called acquired ptosis. So from birth till 1 year of age is called congenital, which happens because of maldevelopment of the LPS. That means that from birth onwards, the levator palpebris superioris is not well developed, it's maldeveloped, and is not able to pull the lid up, which is causing the ptosis. Okay? This is congenital ptosis. And if it comes after 1 year of age, called acquired ptosis. But remember, here's one more thing which I want to talk to you about. This is a question which has been asked recently. In the congenital variety, there's one more ptosis which I'd like to ask you. This is the famous Marcus gun ptosis. Okay, look at this. It's called the Marcus. This is a very recent question which I'm going to include it here. Marcus gun ptosis. What is that? It is the name of an ophthalmologist, Robert Marcus Gunn. Remember, those of you might remember Marcus Gunn pupil also, the same Marcus Gunn. The Marcus Gunn ptosis, it is what? It is also a type of congenital ptosis. That means it occurs before age of 1 year. But here, there is, remember, the abnormal connection between the lid nerves, the LPS, which is the nerve, which is the third nerve, which supplies the LPS, and the fifth cranial nerve, which supplies the muscle of the jaw. So this is also called as jaw winking, syncanthus, jaw winking. So when you open the jaw, the lid flutters open. So normally there is a ptosis, so you will have a child who's born with ptosis, okay? But surprisingly, when the child opens the mouth or chews, chewing movement, like chews like this, or even sucks, the sucking movement or chewing movement, you will find the drooping lid rising up and down, okay? This is amazing phenomena where the lid moves up and down in connection with the chewing movement of the jaws, okay? This is called as Marcus Gunn ptosis, also called as jaw winking syncanthus. Remember, the MCQ is that it is an abnormal connection from birth onwards between the fifth cranial nerve, which supplies the jaw muscles, and the third cranial nerve, which supplies the LPS. Okay, this was asked last year when the question was asked, FMGE, that the mother reports that when the child feeds, remember when the child feeds, so it's a sucking movement. On the child, when the child feeds, the lid seems to go up, or increasing of the lid palpebral aperture. So what is the reason? Remember, the sucking movement caused the lid to go up. So this is an example of a Marcus Gunn ptosis, also called a jaw winking ptosis. So this is congenital also. What about acquired? Acquired ptosis development is after 1 year of age. There are 4 different types. Aponeurotic or involutional is the most common, okay? And this is seen in senile ptosis. Senile means old people who are 75 years of age. You've seen your grandparents. The lid is drooping. Why? Because they have Involutional. What does involutional mean? The word involutional means shrinkage of the tissue. Because of old age, the tissue has shrunken and is not able to pull the lid up. Okay, so this is called involutional, and this is the most common of all the 4 different types of ptosis seen in older people. Also, post-contact lens. Remember, my friends, those of you wearing prolonged contact lenses, 10 years, 15 years, 20 years. Well, you can't be wearing 20 years. Most of you are about 25 anyway. But those who have prolonged contact lens wear, 15, 20 years, they also develop a damage to the aponeurosis, and this can cause an example of aponeurotic or involution ptosis. This is the most common one. What else? Myogenic ptosis. You can see the involution ptosis here. You can see this picture here. This is an old lady whose lid is drooping down. Okay? Myogenic, where the ptosis occurs due to weakness of the muscle, like myasthenia gravis and myotonic dystrophy. So myasthenia, remember, young ladies, my students remember, you people have myasthenia. Okay, remember, myasthenia is very common in young ladies, and those of you looking very tired. Unfortunately, I can't see you. You can see me, but I can't see you, unfortunately. Those whose lids are already drooping, young ladies, remember, myasthenia is the most common disorder of the neuromuscular junction, is it not? So you may have myasthenia. Then ptosis can be seen neurogenic ptosis, which means the nerves is damaged and the nerve is weak, so it's not able to contract the muscles. So example being third nerve paralysis, this is called LPS to droop, and Horner syndrome is due to sympathetic plexus damage, which will cause the muscle, which is what? Remember, the Mueller's muscle is supplied by the sympathetic plexus. So it's the sympathetic plexus which you see in damage in Horner syndrome. So these are examples of neurogenic ptosis. Mechanical ptosis, something is pushing the lid down mechanically, okay, by its weight, like lid tumors or chalazion. Okay, so these are examples of 4 ptosis. So these are the 4 major types of ptosis that you have seen here. The main kinds: aponeurotic, you have myogenic, you have neurogenic, and mechanical. Okay, so these are the 4 different types of ptosis. But please remember, acquired ptosis, the aponeurotic is the most common. Now, what is the treatment of ptosis? Treatment of ptosis, remember, is always surgical. There's no medical management here. And you have to first determine the LPS function. If there's a good function, then we do a certain surgery. If it's poor function, then we do different surgery. The LPS function, if it's a good function, then we do something called LPS dissection. What is that? LPS dissection means that we cut the LPS. You know, and this resection is to cut, you know that, no? So we cut the LPS and stitch it back again. So this shortens the muscle arm and makes it more powerful. It lifts the lid up, and this is you can see the example of a good LPS. This is the frontal. You can see the example here. This is ptosis, and following surgery, you can see that this looks pretty good compared to this surgery. This is very good. This LPS. This is the single most important surgery for ptosis, and can you remember that almost 85% of ptosis are corrected by the LPS. This surgery you have to remember. However, if the LPS function is not very good, if it does not function very good, then you have to do something called frontalis suspension. What we do here, we engage the frontalis from here and we stitch it to the LPS length. Okay, so because there's not enough power in the LPS to pull the lid up by itself, so we attach the frontalis muscle to the upper lid, and when the patient wrinkles the frontalis like this, so it lifts the lid up. It's called frontalis suspension, which we really don't ask you many times. However, to give you completion, poor LPS, we do frontalis. Good LPS, we do LPS dissection. Okay. Then the next topic is lacrimal drainage apparatus. Okay. Remember drainage. Lacrimal, the word lacrimal, kindly remember, always refers to tears. And when you have lacrimal, means the drainage of the tears. Okay. So how do the tears drain? And let's look at this. This is very important for you primarily because the excessive tears that often come during the exam, they have to have a way to drain out, is it not? So where do they drain? From here. So remember, it consists of, drainage apparatus consists of a system of tubes and valves. There are almost 7 different tubes and valves which control the drainage of tears from the eye and finally into the inferior meatus of the nose. Okay, inferior meatus of the nose. That's the final drainage which you can see here. It starts from lacrimal gland here. Okay, remember the lacrimal glands are these 2 very large glands. These are the largest glands in the eyeball complex, and they're present supratemporally. Okay, so somewhere here in the supratemporal area on the upper lid here, 2 glands here, and they produce the tears. And these tears, you can see in the diagram, it goes down to the inferior on the lateral half of the conjunctiva, and from there, as you blink, remember you have to blink like this. This blinking rate, this blink is very important, and this blink, it conveys the tears to the nasal half. from the temporal, it conveys to the nasal half of the eyelid, where there are two small tubes waiting for the tears, two small holes. So this is called the upper punctum. The word punctum means holes, and this is the lower punctum, so on the lower lid. So two small holes, they convey the tears from the upper punctum into the small upper canaliculus. Canaliculus is a very small canal, and then it's from the lower canaliculus like that. Then they combine together to meet for a very short time, which is not mentioned here. It's called the common canaliculus. Okay, from common canaliculus, the common canaliculus goes into this lacrimal sac. Okay, you can see here, lacrimal sac is a small pouch here. You can feel it. You touch it here, there's a small pouch, it's called a sac. Remember, sac. Be careful, do not confuse the sac with the gland. The gland produces the tears, the sac drains the tears. Okay, this is a lacrimal sac where they rest a bit, and finally the tears are pushed down the nose like this. You can feel this huge tube, this long tube called the NLD, nasolacrimal duct. So the tears drain out the nasolacrimal duct like this, and finally they go into the inferior meatus of the nose, inferior meatus of the nose, where they drain into the nose. Finally, that is the drain of tears, and inferior meatus of the nose is where the tears drain finally, where is what our rivalry begins with the ENT surgeons. Remember, the ENT and the ophthalmic surgeons, we often clash on territorial rights. The ENT surgeons say, what are you doing in the nose, which is my territory? I say, but my friend, the tears are mine. Is it not? So we have this territorial fight in the inferior meatus. So this is important pathway to remember, kindly remember. So from the lacrimal glands, it comes as it did you, as you blink like this, the tears are swept into the nasal side. From the nasal side, upper punctum and lower punctum, upper canaliculi, lower canaliculi, common canaliculi, lacrimal sac, nasolacrimal duct, okay, and into the inferior meatus. So this is pathway. So this you have to remember, and also remember that it is the lower canalicus is more important. This system is more important because it drains 75% of the tears here. Okay, so can you remember, because of gravitation, 75% of the tears are drained by the inferior meatus, not the superior meatus. Okay, so drain down that, and from here it goes in the nose like that. Now the problem is that sometimes these things can get blocked, no? Because there are so many tubes here. They can get blocked here. If you have blockage here, suppose the most common site of blockage is this one, the nasolacrimal duct. Write this down, MCQ. This is the most common site of blockage, NLD, nasolacrimal duct here. What will happen if it gets blocked here? Then the tears will go back, they'll reflux, and they will pour down the inferior lid margin like this, which is quartering, inferior lid margin like this. So this is where you have epiphora. So remember, this is a new term for you. We call this epiphora, which is drainage of the tears down the lower lid. Drainage of tears down the lower lid is called as epiphora, okay, because of obstruction of some part of the drainage apparatus, okay. So this is the most common site, and the most important clinical question that I would like to ask you is that a valve, you know, there is a valve here. I told you there is a system of valves here. The valve, this valve, it guards, there's a very important valve here which you have to memorize, which guards the inferior part of the NLD into the nose, so that this valve, you know, opens like this. So it allows the tears to drain down into the nose, but it does not allow the valve, the tears to come back again. Why? Because you don't want the tears that are stained by the mucus of the nose, okay, to get back into the eye and damage it. So as soon as the tears start to reflux, the valve closes like this. Okay? This valve is important, and this valve, you have to remember, is called the valve of Hasner. We just talked about this. Now, in certain children, when they are born, the valve opens immediately, of course, with birth. But in certain cases, say 5 to 6% of these children, this valve remains blocked. It does not open at birth like this. So if it remains blocked, as you can see, it's a persistent valve of Hasner, which means it is persistent, means it is not opened up, it's not canalized. So what will happen is, in about 6% of children, the nasolacrimal duct obstruction takes place. Obstruction, NLDO. So the tears cannot come out into the nose, and because it cannot come into the nose, so they reflux back into the eye, and they pour down the lower lids like this. So this child always looks as if it's crying. This is called as epiphora, and this is the classic triad of NLDO, nasolacrimal congenital nasolacrimal duct obstruction. Epiphora, drainage of tears, discharge because it gets infected, and crusting as it dries up. You see, because these tears now they're stagnant. These tears collect in the sac here, and as they collect in the sac, so will become stagnant, and anything that's stagnant becomes infected. So this infection, when it dries up, is called discharge, and is called crusting when it totally dries up like that. So this epiphora, discharge and crusting, is the sign of congenital nasolacrimal duct obstruction. You can see the kid here. Many of you have seen kids like this. It's pretty common. So the most important question here, because of the watering, remember, there's a very important differential diagnosis. The differential diagnosis is that of congenital glaucoma. Many children's eyes are also watering because they have congenital glaucoma, which is called ophthalmos. Now, this is a far more serious condition than nasolacrimal duct obstruction. So whenever a child's eye is watering, we have to take care to understand whether it is glaucoma, ophthalmos, or is it NLDO. Okay, how do you distinguish? Remember that ophthalmic kids, they have also photophobia, as well as they cannot tolerate bright light. So immediately eyes close, as well as blepharospasm. They're tightly shut lids, and they're extremely uncomfortable. So ophthalmic kids, their eyes be watering, and they'll always be crying. The cranky child is always very crying, very irritable child, because it's very unhappy with blepharospasm, tightly shut lids, and avoiding light like that, okay, like this. But in this case, in congenital NLDO, as you can see, the child is wide open eyes, and he is fairly comfortable. He's not very happy because of the watering, but he's not unhappy, and he's not very irritable, okay. So this is differentiating, and easy to differentiate this. 90% of this, remember, they improve spontaneously. 90% they improve spontaneously. They become fine. Okay, but 10% don't. And for them, we have to treat. We have to do this called digital sac massage. Okay, so you have to treat the mother how to do it. What is that? In the first 6 months of age, you ask the mother to put her finger here. If both eyes, then you have to put both here and gently stroke it down like this. Okay, look at that. You stroke it down 1, 2, 3, 4, like this. Slight pressure, and stroke it down like this. This is called digital massage. What does that do? It increases the pressure inside the valve, and the valve pops open. It valves open like that. Okay, so this is a very nice technique. But remember, this works only for about 6 months of age. After 6 months, it is too stiff to open up like that, so we cannot do this. So after 6 months of the child presents to us, you have to do an NLD probing. So we have a very fine probe, very slender, very delicate probe. It's made of metal and goes right into the nose. Okay, so you take it from the inferior or the superior punctum, goes into the common canalicus, inferior canalicus, lacrimal sac, and right into the nose, and we go pop like that. We push it gently. It has to be done under anesthesia, and we push it gently and breaks the valve. Okay, so this is called probing, but this can be done only up till 2-3 years of age. That's all. Okay, because as the child becomes older, even the valve becomes stiff, and you cannot break it also. And if that also doesn't work, the probing, then we have to do a dacryocysterhinostomy, DCR, after 3 years of age. We have to wait for 3 years of age because of the growth of the nasal bones. Okay, no, DCR cannot be done before 3 years of age. What is that? DCR stands for dacryocysterhinostomy. Okay, like this. Look at that. So what from the dacryocyst means is the lacrimal sac. From the lacrimal sac, we connect it directly to the middle meatus of the nose. So remember, so we bypass this. We bypass the inferior meatus, where, be careful, the tears drain into the inferior meatus, but the DCR opens up into the middle meatus. Okay, so we bypass the entire NLD because we think it's closed, and we enter into the middle meatus like that. This is called DCR, dacryocysterhinostomy. Okay, this is the third step we've done. So kindly remember, this is an important algorithm. You have to memorize this. First 6 months, sac massage, then doesn't work, go to probing, and if probing doesn't work, then you do DCR, but you have to wait for 3 years at least. Remember, 3 years, not months, 3 years before you do a DCR. So with that, ladies and gentlemen, we have now finished our orbit and oculoplasty. These are the 5 most important topics: orbit and oculoplasty. And if you've done this and you can answer these questions, you've done well up in the ophthalmic MCQs. Then we come to cataracts. Cataracts, remember, is the single most common cause of blindness in the world. Remember, blindness, the first quiz, cataract defined as, you can remember, opacification of the lens or cataract. Okay, opacification of the lens or capsule, I beg pardon. It can be the lens or capsule. This is called a cataract. So this is the lens and capsule opacification. It's called cataract. You can have either or both. Cataract is also, remember, the world's most common cause of blindness. Almost 50% of the world's blind are because of almost 50%. That's a huge figure. India is almost 70% of these blindness because of cataract. Okay? And what exactly is blindness? You have to remember the definition of blindness according to NPCB, which is National Program for the Control of Blindness, which is the governing body in our country, and also WHO, which governs the entire world. Anybody less than 3/60, okay? That is, if you cannot read the first line of the Snellen's chart from a distance of 3 meters, it means you're less than 3/60, then you're considered blind. But also remember, this vision is taken with glasses. It is not taken without glasses. So if you're wearing glasses and still not able to read 3/60, it means you're blind. Okay? And it is taken with the better eye. So suppose you have one eye 6/6, the other eye is 1/60. This is not blindness because the better eye is 6/6. You have to check the vision of the better eye, and that should be less than 3/60. Okay? So if you have one eye 1/60 and the other eye 2/60, this is blindness because this is the better eye and this is less than 3. Is it? That's important. So kindly remember the caveats that you are blind when if the better eye wearing glasses is less than 3/60. That is the blindness. Okay. So this is the typical definite blindness, and as I told you, the world's most common cause of blindness is cataracts. Okay. So which is the most common type of cataract? The most common type of cataract is age-related cataract. Age-related cataract is people above 60 years of age almost, we call them, those who develop cataract after 60 years of age. This is almost 80% of cataracts are because of that, okay? 80% of cataracts. So kindly remember, there are many types of cataract causes like age-related, okay, like metabolic, like complicated, like steroid-induced cataracts, but the most common type, single type, is the age-related one. And what is the reason why older people develop cataracts? Because the most common reason causing cataracts is the exposure of ultraviolet light. As we all grow old, so we have more exposure to ultraviolet light, and the ultraviolet light, it damages the lens capsule and the lens proteins and causes a cataract. Okay, this is the world's most common. Then what about the other morphological differentiation? Remember, morphologically, it depends. We divide into 3 types of nuclear, cortical, and posterior subcapsular cataract. If the nucleus is opaque, then we call it as a nuclear cataract. If the cortex is opaque, the periphery of the lens is opaque, we call it cortical cataract. And if the cataract is close to the posterior capsule, then we call it a posterior subcapsular cataract. Okay? So you can have all 3, of course, in the same cataract. All 3 can be possible. It can be 1, it can be 2, or all 3. Let's talk about nuclear cataracts, which means the center of the lens is opaque like this. Center of the lens opaque. This is the nucleus to become cataractus. And here we have 3 MCQs. Look at that. Look at the color. This yellowish color that you see, it's called amber. Actually, if you want to know the correct name, it's called amber color. And the yellowish layer, it becomes amber. That is the sign of a nuclear cataract. Remember, normal cataracts, normal lenses are transparent. A lens does not have any color. But when it becomes yellowish amber, it means you've got a nuclear cataract. And this is a nuclear cataract which you see here. That tells you what are the 3 MCQs. First of all, it causes index myopia. Okay, what is that? Because these rays of light, they focus in front of retina. When you have a nuclear cataract like this, look at this. Because of the increase of refractive index, they bend more light, and the light comes in front of retina, so they become myopic. Okay, so they become myopic, and that is why they will complain the same as a myopic patient, which is, doctor, I can't see distances. So nuclear cataract says, doctor, I can't drive, I can't watch TV, however, I can read. So you don't have a problem in reading. Nuclear cataracts are well known for the fact that near vision is preserved, but not the distance vision. The second is called hemorrhalopia, which means that they have day blindness. These patients are not able to see very well in daytime. Why? Because in the daytime, the pupil constricts, there's too much light, pupil constricts. So when the pupil constricts, the rays of light go only through the center. They only through the center, the nuclear cataract is in the center, it will block the rays of light, so they can't see in the daytime. But in the night time, the pupils dilate. No, they will dilate like that. So when they dilate, the rays will go to the periphery. The periphery is the cortex, and the cortex is clear, so they will be able to see. So paradoxically, kindly remember, these patients cannot see very well in the daytime, but they see very well in the night time. Okay, this is called day blindness, hemorrhalopia. And second sight is a condition where their near vision improves. Okay, because why? Because of the myopia. So remember, those of you who've done refractive errors, you know that after 40, all of us, we become presbyopic, is not loss of cognition with age. So after 40, we all need glasses to read. But this patient, because he becomes myopic, so initial presbyopia, which is rays of light we're focusing here, the myopia forces the rays of light on the retina, and paradoxically, his near vision improves. This is called as second sight. Be careful about nuclear cataracts. When you have a nuclear cataract, the distance vision becomes worse and the near vision becomes better. This near vision improvement in nuclear cataracts is called second sight. It's called second sight because this patient will become presbyopic at 45 and vision dropped at 45, now recovers vision, near vision, due to the index myopia created by the nuclear cataract. This is called second sight because he gets it back again. Okay? So this is the three important MCQs of nuclear cataract, and be very careful that you do not miss these questions. What about cortical cataracts? Cortical cataracts are cataracts in the cortex, in the periphery, and we call them cuneiform cataract. Why cuneiform? Because look at that, they look like this. The wedge-shaped cataract, wedges, or fork-like cataracts. They have this wedges cataract here. Cortical cataracts are cuneiform-shaped cataracts. And the third one is our favorite cataract. Remember, the posterior subcapsular cataract, which means close to the posterior capsule. These are our favorite questions for asking MCQs because remember, they cause the maximum visual handicap. That means of all patients, these cataracts have the poorest vision. Of all cataracts, these patients have the worst vision or the poorest vision. Why? Because remember, they have the maximum glare. That is unwanted light. Glare means when light is radiating out from point source of light and they are washing out all the details, they do not focus on the fovea. Okay, you get a glare. Those of you who've seen at night, if you're driving, particularly with your spectacles on, you get a lot of glare. So maximum visual handicap because they have the maximum glare. But why should they have maximum glare? Because they have maximum glare because they're located closest to the nodal point of the eye. The nodal point of the eye, remember MCQ, is also located on the posterior capsule. The posterior subcapsular cataract is also on the posterior capsule. So this coincidence of the posterior subcapsular cataract right next to the nodal point of the eye causes the maximum scattering of rays of light in posterior subcapsulars and causes maximum glare. Okay, the glare of PSC is well known. You can see the glare here that you can see. Okay? Look at the glare here of the oncoming lights, headlights. So please remember again to summarize, posterior subcapsular have the maximum loss of vision because they have the maximum glare. Why? Because it's situated closest to the nodal point of the eye. Why? Because the nodal point is also on the posterior capsule, so is the posterior subcapsular cataract. And one more question, remember, posterior subcapsulars, they have loss of near vision. PSCs, they can't read very well. Why is that? Because of the pupil constriction. Remember, when you see for near vision, you have three things. You have accommodation, you have convergence, and you have constriction. Okay? So when you read for near vision, your pupil constricts. But when the pupil constricts, the posterior subcapsular cataract blocks the entire pupil because of the constriction. So none of the rays can pass through. Remember, a well-known characteristic of posterior subcapsular cataract is they have problems of reading. So be careful. Nuclear cataracts have very good, near vision, but poor distance vision. Posterior subcapsulars have poor near vision. Okay? So that distinguishes between the two cataracts by the symptoms alone. Very well. So then we have done the types of cataracts. Let's look at some of the other types of cataracts also. So remember, I'm getting a lot of questions here. So we will just tackle these questions after I finish this thing. Don't get worried. I am going to answer your questions. Okay? And let's look at that. So what we have is the most common type of congenital cataract. That means children born with cataracts, congenital cataracts. This is a very famous cataract called zonular cataract, also lamella. You can see it here. Can you also see zonular cataract? It's called a zonular cataract because of the specific zone. See the entire lens. You can see the entire lens is clear, but a small zone of the lens is opaque. That's why it's called a zonular cataract. It's called zonular cataract because it's a very small zone of the lens opaque. Okay, and this is the most common type of cataract causing blurring of vision in children. Can you remember again what did I say? Remember, it's not the most common type of congenital cataract. No, that most type of congenital cataract is a more common type of than this. It is called a blue dot cataract. Blue dot cataract, it's small dots are there, also called as punctate cataract. Punctate means dots. Okay, that is more common, but this is less commonly asked. Okay, because they don't cause loss of vision, so we are not interested in cataracts which don't cause loss of vision. The most common congenital cataract which causes loss of vision is this one, we call zonular lamella, as you can see here. Then the key critical period of fixation, that is the time at which the fovea develops. Remember, the fovea is the single most powerful area of the lens, of the retina. And this fovea normally collects 80 to 90% of light and gives the best possible vision. But this fovea is not mature. It's not developed at birth, and it develops maturity anything between 2 to 4 months of age or approximately 3 months of age. So you have to remember this, because at 3 months of age, when the fovea develops fixation or the fovea becomes mature, the vision rises very much so. The child's vision improves dramatically after 3 to 4 months because the fovea is now ready. Then another powerful question is the rosette. Rosette, remember, the word rosette means like the petals of a rose, okay? Like the petals of a rose, you can see here, rosette cataract. It's like the petals of a rose, and it's very famous because of a shape. But also remember, rosette cataracts are a sign of trauma. So when you get hit in the eye, you can develop a rosette cataract. But also remember, rosette cataracts are not overnight. Rosette cataracts take time to develop, okay? It takes often some 5, 10, 15 years. So they cannot get overnight. So you cannot have a rosette cataract, let's say, immediately the next morning after trauma. So suppose you get a question which states that the cataract occurs immediately after following trauma, then that is not a rosette. That is some other type of cataract, okay? And they're trying to fool you with the question with the history of trauma. Remember, so rosettes are a sign of trauma. Then what are complicated cataracts? Remember, complicated are important because these are favorite cataracts. The word complicated cataract means cataract due to some disease of the eye, second disease of the eye, okay? So there has to be some disease of the eye. So if you have diabetic cataracts, that's not complicated cataract, because diabetes is not a disease of the eye. So any other disease of the body causing cataracts is not an example of complicated. It has to be specifically disease of the eye. And so the most common cause of complications are uveitis, because that's disease of the eye. Uveitis, you can have glaucoma, you can have myopia, you can retinitis pigmentosa. All these diseases of the eye causing cataracts, we call them as complicated cataracts, okay? And complications have 3 important characteristics, which is posterior subcapsular. Usually these are close to the posterior capsule. We call them posterior subcapsular. Second, these are polychromatic. Polychroma means multiple colors. So you will see a rainbow-like hue. These are very beautiful cataracts, let me tell you, okay? They look like, shine like a rainbow. So often you ask that, which cataracts have a multiple color shine or polychromatic shine or luster? You will say a complicated cataract. And third is the breadcrumb appearance. Breadcrumb appearance means they look like crumbs of bread, you know, the grayish white breadcrumbs. And remember, this is not the breadcrumbing, which a lot of you Gen Z doing this to your friends. It's not that breadcrumbing that I'm talking about. And those of you who don't know what breadcrumbing is, too bad. I'm not going to explain it here. Okay, this is called the breadcrumb appearance. Remember, they look like breadcrumbs. You have to call it breadcrumbs. You know, many of my Tamil and Chennai students, they want to call it idli crumbs. You can't call it idli crumbs. No. What else? Then you have the snowflake cataracts. They look like flakes of snow, and snowflake cataracts is a very important cataract. It's a diabetic, it's a true diabetic cataract. Remember, they look like flakes of snow. And the powerful oil drop cataracts. The oil drop cataract is like a drop of oil, and this is very well seen in galactosemia. So look at the question, remember, this combination of questions is important. A newborn child presents to you with mental retardation and cataracts. Okay? What kind of cataract do you expect? Remember, mental retardation cataract is typically seen in galactosemia. These kids are born mentally retarded. So if you have a common mental retardation with cataracts, you know that's going to be galactosemia. So the answer will be an oil droplet cataract. Okay, so be careful. Oil drop cataracts look just like a drop of oil. Then the Wilson's disease has a sunflower cataract. Looks like a sunflower. The Wilson's disease will cause a. So remember, two ophthalmic findings of Wilson's disease. You know already more. The more common one is the. You all know that. What is that? It's called the. Well, what is called? You can answer me. The ring, which is called the Kaiser-Fleischer ring. Remember the KF ring? The Kaiser-Fleischer ring, KF ring, is the more common ocular finding. The less common is sunflower cataracts of Wilson disease. Okay? It looks like a sunflower. And the famous Christmas tree cataract is myotonic. Christmas is round the corner, but the myotonic dystrophy is even more around the corner. They are present everywhere. They shine like a Christmas tree, you know, shining and coruscating like a Christmas tree. Then what is about a glass blower's cataract? People who work in glass blowing industries, melting sand and silica at 2000 degrees centigrade, they get exposed to intense amount of heat. They develop a heat cataract, which is called a true explosion cataract. And so glass blowers cataracts are cataracts seen glass blowers cataracts are seen in heat cataracts. So they're not very commonly seen, okay, but they can be seen. People who work in steel industry, they get also exposed to a lot of heat. So these people, we also call them iron workers cataracts because they are working in steel industries, making steel from iron. And a lot of your parents work in steel industries like Tata, Tisco, SAIL, the plant in Salem, the plant in Jamshedpur, They often work as developing these steel plants. They often develop cataracts. Remember, they're examples of heat cataracts. So two examples of heat cataracts, glass blowers and the iron workers cataract. Then certain drugs also cause cataract. You have to watch out for them. Look at the ABCD drugs of cataracts. Okay? A for amiodarone, antiarrhythmic. B for busulfan, anti-cancer. C for chlorpromazine, okay? That is antipsychotic. So chlorpromazine is a very powerful antipsychotic, and this may cause cataracts over many years. C also for chloroquine. Chloroquine is for malaria, of course, but malaria is only 3 to 4 years of treatment, so that doesn't cause cataract. However, we do use chloroquine, derivatives of chloroquine like hydroxychloroquine for things like rheumatoid arthritis. That is a prolonged treatment, and that may cause cataracts, okay? The ABCD, D is dexamethasone, the steroid, and this is the systemic. So remember, of all these drugs, the ABCD drugs, A, B, C, D drugs, Dexa, which is steroid, is the most common drug causing cataracts. Please remember, systemic steroids by mouth cause the most common cataracts. These drugs also, of course. Remember, steroids can cause, any steroid can cause cataract. Injectable steroid, topical steroid, steroid creams, steroid ointments, steroid aerosols, steroid sprays, inhalers, every little kind can cause cataract, but the most common is by mouth. Oral steroids cause the maximum cataract, drug-induced cataract. So these, remember, steroids are the most. So some of you who are on steroids for whatever reason, bronchial asthma, or those who go to gym to pump iron, remember, be careful, you'll land up with cataracts. Then another question which you'll have to ask you, particularly in NEET PG, which can be seen in diabetic cataracts, is the famous fluctuation of vision. The vision fluctuates, okay? In the morning it's 6.6, in the evening it's 6.6, 6.9, in the night it is 6.12, or vice versa. So if you have fluctuating vision, watch out for diabetics. So in fact, many times you'll be able to diagnose diabetes just by looking at the history of fluctuating vision, okay? So you have diabetic cataracts. So these are cataracts questions. Then the next things we want to talk about, that every cataract undergoes 4 stages. Every cataract undergoes 4 stages. So let me know if the speed is okay, most of you, because I'm going a little fast because I don't want to take too long for this. I said the whole thing should be over in 7 to 8 hours, but if possible faster, because but if I'm going too fast, please tell me to slow down, because as most of you are aware, I am very, very fast in every way, isn't it? Very well. So let's look at the 4 stages of cataract. What is it? Incipient, immature, mature, and hypermature. These are 4 stages. All cataracts pass through 4 stages. We have to know them. The word incipient means early. Okay, like you people are incipient doctors. Okay, early doctors. Okay, immature. So incipient is the earliest phase of cataract where there are hardly any symptoms. There are hardly any symptoms. Patient does not complain to us. They don't come to us most of the time. Okay, then a few months later it becomes immature, which is defined as a partially opaque cataract. Okay, so some areas are clear, some areas are opaque. It's a partially opaque cataract. You recognize this because the vision, loss of vision is more. It's called moderate loss of vision. So it will be 6.18, 6.24, 6.36, etc. Unlike incipient, which have 6.6 or 6.9. Okay, so there are more loss of vision. You recognize this by the grayish yellow color of the lens. Remember that I told you lens is transparent. Normally, a clear lens will be transparent. This is yellowish gray in color, and you will get an iris shadow here. This is finally called iris shadow, which will tell you that it's a mature cataract. About 50% of these patients come to us because they realize they have blurring of vision, and we take care of them. Another few months, and it becomes a mature cataract. Okay, mature cataract, remember, means completely opaque, and it's totally opaque, right? This, so nothing can pass through. The vision becomes hand movement of finger counting. Because remember, you can diagnose the stage of cataract by the vision. So if he says hand movement of finger counting, it means it's a mature cataract. If it's 6.18, 6.12, it's immature. If it's 6.9, if 6.6, it's incipient. Okay, so this is a totally mature cataract, and the mature cataracts often cause glaucoma. Remember, they swell up, and this swollen lens is called intumescent cataract. Okay, so remember, intumescent means swollen up, and intumescent stage is seen in mature cataracts, and they cause glaucoma. So remember, MCQ can be asked is possible, is that which stage causes the highest amount of glaucoma? which stage of cataract high glaucoma is a intumescent cataract, or if intumescent not given, you can answer the highest is seen in mature cataracts. And finally, if 10% of patients, by mature cataract, 90% of patients have come to us because they can't see anything. But 10% of patients don't come to us, they are in hypermature state. They still don't come to us because they still can't see anything, but they don't come to us because these are completely apathetic patients. They don't care if they live or die, they don't care if they see or not. But they do come to us in last stage hypermature, where the lens shrinks. With the loss of water, the lens becomes very small, so very small white lens is called a hypermature cataract and keeps moving around all the time. Why? Because it's a very small lens, so the zonules cannot hold this. Originally, the zonules were holding this like this, but now they can't hold it because the lens is too small, and this lens starts moving and shaking and rocking. Okay, like Shakira, it keeps rocking all the time, and this is the hypermature cataract. Okay, remember, all cataracts pass through these 4 stages. Then, after many symptoms of cataract, you have to remember 3. The classic 3. What is that? Blurring of vision. Patient says, "Doctor, I can't see." And there's no pain. Remember, it's a slow, painless blurring of vision. Remember, many times you have loss of vision with pain. Cataracts is not one of them. It's a painless, gradual blurring of vision. Second, you will have double vision, or sometimes you have polyopia, multiple vision. Remember, doubling of vision in that particular eye. If you have cataract one eye, then with that eye you will have doubling, either doubling or multiple vision sometimes. If you have both eyes, one eye is normal, other is cataract, you will have not doubling. You will only have doubling with that particular eye. Okay? Doubling or multiple vision polyopia. And the famous colored rings, which are seen in colored halos, which is so frightening to the patient. He sees these colored rings all around, bulbs of light. So you have the classic symptom, remember, blurring, polyopia, diplopia, and colored halos. Okay? This is the thing that you have for cataracts. Then what about the treatment? So when you have diagnosed cataract, remember, there are only 2 treatments. Either you give them glasses or you give them surgery. Okay, that's all. Glasses you give in the earlier phases, incipient and immature. Okay, but if they are mature, you have to operate them. Okay, so late for surgery. And also remember that for younger patients like you people, okay, we would try to avoid surgery. Why? Because you see, if we remove the surgery, if your lens is removed, then we take out 19 diopters of lens, which carries loss of distance vision, and you would lose accommodation. Remember, accommodation depends upon the lens, which is for near vision. So if I take out your cataracts, then your near vision would be lost. You still have distance vision, but you won't have the near vision. So for younger people, near vision is important because you have to write to exams, and do many other things, exams apart from that. So near vision will be a major loss of vision for cataract surgery. So we can operate on older patients about 40-45 because they've already lost their near vision because of presbyopia. But for younger patients less than 40, we would not like to operate because we will sacrifice their accommodation needlessly. So let's look at the surgical indications. So remember, there are 2 important indications. First, they are advanced cataracts, they are mature, hypermature. Second, if they're visually handicapped. Visually handicapped means you have to ask them that, look, are you visually handicapped? Which means, can you do your day-to-day activities? A person who cannot do his day-to-day activity is called visually handicapped because he cannot earn his living. So a driver who can't drive is visually handicapped. Operate him. A plumber who cannot fix the pipes is visually handicapped because he is economically handicapped. Operate him. A teacher who cannot see his own students and the exercise books is visually handicapped. Operate him. So people with visual handicap and people with mature cataracts need surgery. Okay, and so you see, this is typical blurring of vision, which you see. The blurring of vision, you see the outlines are visible, but the details are hazy. Okay, so that is typical loss of vision in cataracts. This little vision. Then let's look at some of the few surgeries. Remember, cataract happens to be one topic in ophthalmology where the surgeries are asked. Otherwise, most of the surgeries we don't ask you in ophthalmology, but cataracts, yes. So the first one is ICC. Remember, it stands for intracapsular cataract extraction. Intracapsular cataract extraction. What is that? You take out the entire lens and the capsule. You take out both together. Okay? And so this creates a condition which is called aphakia, which is the absence of the lens. Remember, phacos means lens. So aphakia means absence of the lens. You've taken away everything out. So you give them these thick glasses which will correct for the distance vision, but they cannot give a near vision. So this is aphakia, and aphakia, remember, has a lot of problems. Why? Because you see, because you wear these glasses which are thick lenses. Remember, you have replaced a lens which is 19 diopters of power, is not? You want to give them glasses, the glasses will have very high power also, 15 diopters. Such thick lenses, they will cause magnification because these are convex lenses, and remember, each convex lens diopter magnifies by 2%. If you wear these thick lenses, you have a 30% magnification, which means that you will not have fusion. Remember, I told you, or you should know, that fusion occurs when the maximum difference in image size should be 5%, not more than 5%. If it's more than 5%, you're not going to fuse, you will have diplopia. So these patients land up with diplopia. A jack-in-the-box glaucoma, where your jack-in-the-box is a toy. When you open the toy and it comes out like a spring like this, jack-in-the-box. So this is a jack-in-the-box where you wear this thick, patient wears thick FAK glasses, and at a certain point, he finds objects disappearing suddenly. You can see somebody coming like this. At a certain point, which is about 50 degrees away from the lens, this object suddenly disappears. Why? Because at this particular thing, the rays of light, they strike the edge of the lens, and the rays go out like that, reflecting out. So suddenly this person here, he disappears, and as he walks out of that area, he again reappears like a jack-in-the-box. Okay, this is a very powerful and very famous optical illusion of aphakia. We call it a jack-in-the-box. Then we have a pin-cushion distortion. Pin-cushion distortion means everything appears to be distorted like this. Okay? All the buildings, all the people, all the cars, all the trees, they appear like a pin-cushion, bent outwards like this because of the high magnification power of the convex lenses. So this is a world without any straight lines. It's very disorienting, let me tell you. Okay? So these are the three important MCQs that you have, and they have loss of orientation also. They cannot judge depths. So on trying to pour water into a cup, they will pour it over themselves. Trying to drink water, they may spill it on themselves. Okay, they fall down the stairs, they fall in the streets, they can't walk properly. So multiple side effects of aphakia. We hate aphakia. We don't do aphakia anymore. So we don't do this surgery called intracapsular surgery anymore, except for one particular indication, which is what? Which is a subluxed cataract or dislocated cataract. So the next surgery that was discovered, invented, was the ECC. What is that? Extracapsular cataract extraction. Here what we do, here we take out the lens, but we leave the capsule. Okay, see, this was the capsule like this. So we take out, make a small opening here, and we take out the cataract, place the intraocular lens here, and we leave the capsule behind. So the whole point is that we make a small opening in the capsule, and we do not remove the entire capsule. From this, we remove the cataract and we place the IOL. So the intraocular lens, this is called IOL, which is one of the great inventions of the ophthalmic world. And the next one, when you open the bandage, the rays of light are focused by the intraocular lens perfectly on the retina. Patient get a very good vision around 6:18 the next day. This whole surgery, we call it, this IOL is called a posterior chamber intraocular lens, PCIOL. A posterior chamber intraocular lens, because it's on the behind the iris, and this whole surgery is called ECC with PCIOL, extracapsular cataract extraction PCIOL. And this condition, when you have an artificial lens, it's called as pseudophakia. Remember, pseudo means artificial, aphakia means no lens. So when you do intracapsular, the eye becomes aphakic. When you do ECC, it becomes pseudophakic. Anytime you place an intraocular lens, it becomes pseudophakic. Okay. So the next thing, surgery, the most advanced surgery nowadays, is the phacoemulsion. This is what we do. Phacoemulsion means stitchless surgery. Okay. So what we do, we make a very small incision. Okay. So either through the sclera or through the corneum. It's called a tunnel. It looks like a tunnel because it has walls and it has a roof and a base. It looks like a tunnel. We can make a very small opening through this, which is less than 2.8. It's less than 3 mm, around 2.8. And through this, we induce a probe which breaks down the cataract and takes it out. It has to emulsify. That's what emulsification. Okay, it breaks it down by hammering it away with mechanical hammering away at the rate of 40,000 times per second. It breaks down the cataract, takes it out from there, and we squeeze in an IOL, a foldable IOL. Remember, this IOL is very flexible and can be folded like this. You fold the IOL, you put it inside, and unfolds inside beautiful like a flower. And this, because the opening is so small, less than 3 mm, and because it's made in 3 different planes, okay, it goes 1, 2, and 3 in planes 1, 2, and 3. And remember, single plane will not self-seal, okay? But this is in 3 planes. You have 1, 2, and 3. It's a multiplanar. It creates a valve, and this valve seals the incision. So this creates, we do not have to stitch this incision. We don't have to put a stitch or a suture. It automatically seals. It's a self-sealing incision. And this we put a foldable IL. So the next stage of vision is 6 by 6 because there is no stitches, no distortion of the cornea, no astigmatism introduced. The patient develops very good vision. Okay. So this is the principle of the phaco, which you do nowadays, the most popular surgery. And then because phaco is expensive surgeries because we need a phaco machine and we need the foldable IOLs, which are expensive, and we need all these instruments, which are expensive. So everybody cannot afford a phaco in our country. So what we have, particularly for India and most South Asia, we use this very important surgery called SICS. It stands for Small Incision Cataract Surgery, or Manual Small Incision Cataract Surgery, where again we make an opening, but it is not that small as phaco. Phaco is less than 3. There it is 6 mm. You can see it here in this picture. See, this is approximately a 6 mm incision like this, and through this again we make in 3 planes, 1, 2, 3. So it is again self-sealing. Okay, so we take this thing and manually extract that. So we break the lens with the force of our own hands. Okay, in a phaco we use a phaco machine which breaks down, hammers the lens down by relentless action of a ultrasonic probe. Here we break it down manually with the force of our own hands, and we take it out through a 6 mm opening. And so what happens is, here we don't need a foldable IL because the opening is 6 mm, and we don't use a foldable IL because we don't have to fold. So this reduces the cost. Okay, we use a PMMA, and here also no stitches are required. Why? Because 6 mm is enough to maintain the incision. Also remember, we make in 3 different planes. So anything more than 6 mm cannot stay without stitches. So if you keep it under 6 mm and you make it in 3 different planes, so again no stitches are required. So again the vision is 6 by 6 after cataract surgery. So this is economically very viable. We don't need a phaco machine. We don't need a foldable IL. We don't need powerful instruments. So we get the very good vision of phacoemulsification because again there are no stitches here without the phaco machine and its cost. So this is a very important surgery which we do in South Asia and India, where economically weaker countries. So SI says, remember, your question can be asked that this is the most commonly performed cataract surgery. This is the most commonly performed cataract surgery in India and South Asia. Okay. And then remember, so what are other questions possible? Remember, it's a slightly bigger opening because 6 mm, no, because after all, you're breaking down the lens with your own hands. This can never be as minute as the small fragments with the phaco machine. So it is a bigger incision, and remember, we don't need a foldable IL. Very well. Now the latest surgeries that have been introduced about a few years back only, it's called FLACS. It stands for Femto Laser Assisted Cataract Surgery. Okay, there's a new laser which does do cataract surgery, and this laser, what it does, this laser surgery, it has 2 advantages. So it creates perfect. See, when we have to take out the capsule, we have to cut the capsule. No, we have to cut it capsule with our own hands. No, that's called capsule rhexis, and that's manually. So here the laser beam performs a rhexis, which is a perfect circle. See, when I draw a circle like that, this is my rhexis. You can see how it's ragged. It's irregular. Isn't it? So with a laser, it creates a perfect rhexis, and that is why this FLACS is this advantage of a perfect capsule rhexis, and it's a very tight incision because we don't use a blade here. We make the incision with the femto laser itself, so there's no leakage here. So these 2 advantages give, it's a lot of advantages. It's called FLACS, but unfortunately it's very, very expensive. In our country it's very expensive, so most of us, we don't do FLACS, but many of us do. And this is the last surgery. So remember the advantage of femto laser, FLACS, femto laser assisted cataract surgery. The laser is used as femto. The 2 advantages, it creates a very tight opening and creates a perfect rhexis, but it's too expensive. It's a bit like phaco. Again, it's stitchless. Remember, there are 3 stitchless. Sorry. Yeah. Remember, of these phacoemulsification, SICS, and FLACS, all these 3 are stitchless. We don't apply stitches here. And the stitches that we use here are in ICC and ECC. So of the 5 surgeries I have described, only 2 of them have stitches. ICC, which is the oldest one, and ECC, which also is pretty old. The rest of these 3, phaco, SICS, and FLACS, don't require stitches because they're all small incision. All of them are multiplanar. Okay. Then an MCQ about a refractive question. Okay, a refractive questions of IOLs. what about the IOL power? What are the IOLs? And then let's look at intraocular lens. Remember, we have to remember that we have to calculate this power for everybody. Remember, just as you all wear glass of different power, you know, somebody's wearing -1, somebody's wearing -2, somebody's wearing -3, for +1. Similarly, for every patient who do cataract surgery, we have to calculate the IOL power, okay? This IOL power is calculated by a technique called as biometry. You see why? Because when you place intraocular lens, remember, the rays of light have to focus perfectly on the retina, no? Only then will you get good vision 6/6. No, the IOL has to be absolutely correctly powered, no? So, for instance, most of the IOL powers that we put, the most common IOL power is around 21 diopters, okay? This also you can remember as MCQ. What is the most common power of the IOL implanted? The most common power of IOL implanted is about 21 diopters, because remember, our lens carries 19 diopters, no? All of us remember the normal power of the crystalline lens is 19 diopters. The IOL is also close to that 21 diopters. But suppose, but all of it is not 21. I could be 21, yours could be 22, his could be 23, somebody could be 19. But suppose, so this power, what exact power has to be calculated for the IOL implantation is checked with a biometer. Remember, biometer is the instrument which checks the IOL power. Don't confuse biometrics. Biometrics is your fingerprints or for iris scans for identification of a person. Isn't that biometrics? This is biometry. Okay? And this biometry requires two important investigations which you need to know. One requires the axial length, the eyeball size, okay, which is mostly 24, most of us, and keratometry with corneal curvature. So remember, MCQ can be asked, which two variables are required to calculate the IOL power? We require two variables, the corneal curvature and the axial length. Okay? For every patient that I want to do cataract surgery, suppose I want to do cataract surgery for any of you, then I would calculate your keratometry, your axial length, and then this will give me the correct IOL power. Then remember foldable IOLs, you have to remember the two materials, acrylic and silicone. We have the two of them, acrylic and silicone, two different types of IOL. You have to remember both the names. But non-foldables are not acrylic or silicone, they are less expensive and they are made up of PMMA, a type of plastic, polymethyl methacrylate, PMMA, polymethyl methacrylate. And the lowest incidence of PCOs, remember, PCOs are what? Secondary cataract. You know that most of the secondary cataract, the most common complication of cataract surgery is sometimes called secondary cataract or called as PCO, posterior capsular passivation. So there's another MCQ. The lowest incidence of PCOs is with hydrophobic cataract. Now this is a more advanced MCQ and this is mostly asked in NEET PG, but you might as well know it because a lot of questions are borrowed from NEET PG. Okay? So please remember, and in fact, I must tell you something, ladies and gentlemen, you have to listen to me. In the last 2-3 years, I have found, and many of my faculties, our faculties think so too, that the FMGE exam is becoming more difficult than the NEET PG itself. This is not only my impression, but other faculties, so you have to watch out. Okay? Kindly remember, the secondary cataracts depend on the material of the intraocular lens that you place. And the IOL with the least amount of secondary cataracts or the PCO, which is desirable because we don't want to have secondary cataracts, is this particular acrylic IOL, which is called hydrophobic. Hydro means water, phobic means hating, so it repels water, hydrophobic. So this is a kind of acrylic IOL which repels the water, and this has the lowest incidence of secondary cataracts. Many of you ask me, many of my students ask me, sir, my parents are getting operated and the doctor has given us the choice of intraocular lens to be implanted. Which IOL should I ask them to implant? Remember, ask for a hydrophobic acrylic IOL. This has the least amount of secondary cataracts. Okay? Then what happens, remember, when you place the IOL, you will always have to wear glasses, no? Because there's no accommodation. There's no accommodation, so you have to wear glasses. But supposing there is a patient who doesn't want to wear glasses after cataract surgery, there are many patients like that, they hate to wear glasses after cataract surgery. In that case, we have a special IOL, we call it a multifocal IOL. Yeah, multifocal IOLs have two different foci, one for distance, one for near. So if you implant a multifocal IOL, then you will not require to wear glasses. But they are expensive and they have their own problems. The world's most common intraocular lens implanted is a monofocal. Okay, is a monofocal. That means it carries only the distance power. You have to wear glasses. Okay, but multifocal IOLs where you don't have to wear glasses because they will also have a focus for difference. But they are expensive and their own problems. And then the complications, which I was telling you, remember complications, you have the first one, as I told, this one, PCO, also called the after cataract also called a secondary cataract. This is the most common complication of cataracts. Okay, remember, almost 50% of patients have the secondary cataracts. You have to remember the two names. The Elschnick's pearl is the most common, and Sommering rings is less common. Okay, there are two, pearls and rings. Okay, remember, pearls and rings sounds like a jewelry shop, but it's not a jewelry shop. It is a very much an ophthalmic shop. Okay, Elschnick's pearls are more common, Sommering rings are less common. How do I treat them? Secondary cataract, I open the capsulotomy by a laser which is called the Nd:YAG laser. Can you remember? This is the second laser of ophthalmology, but this is the most important. We already discussed one laser, which was femto. The second laser is the Nd:YAG laser, which has, you have to memorize the wavelength is 1064 nanometer. What is the full form of Nd:YAG? You have to remember neodymium, yttrium, aluminum, and garnet. Neodymium, yttrium, aluminum, and garnet laser with 1064 nanometer. So this is the second laser we've talked today, and this is the most important laser of entire ophthalmology. There are 6 lasers, we'll discuss all of them. Then another complication is Irvin gas syndrome. What is that? This is post-surgery cataract cystoid macular edema. Whenever you have cystoid macular edema, that's this edema over the macula, taking small cysts, we call cystoid macular edema. The cystoid macular edema occurs after a lot of ophthalmic surgeries, but occurs particularly commonly after cataract surgery, and this is called as Irvin gas syndrome. Please remember this famous name, IGS. Irvin gas syndrome is the phenomena of cystoid macular edema occurring after cataract surgery. It is also very common. It also causes slow, painless blurring of vision. So overall, most common cataract complication, of course, secondary cataract. So Irvin gas syndrome is another complication. Remember how we diagnose it? We diagnose this by not only by the loss of vision, but also by this symptom called as metamorphopsia. Metamorphopsia, which is distortion of shape. Okay, you know, morphology means shape. So all the straight lines like this, they will appear wavy and distorted like this. This is called metamorphopsia. Okay, so whenever you have this wavy lines like this, it means you are suffering from some macular pathology. It could be CME, it could be CSR, it could be ARMD. Any macular pathology, the non-specific about it, the vision appears to be distorted. It's called metamorphopsia. Okay, so this is a sign that you have CME. Then the most common dangerous complication of this is called as complication of cataract is called endophthalmitis. Look at that. The word endophthalmitis means infection of the vitreous cavity. The endophthalm means vitreous. So it is an infection of the vitreous cavity, and there are 2 different types of endophthalmitis. One is called early onset if it occurs in less than 6 weeks after cataract surgery. If it occurs within 1.5 months of cataract surgery, this is called early onset endophthalmitis. If it comes after 6 weeks or 1.5 months after cataract surgery, we call late onset. Okay, the early onset endophthalmitis is caused most commonly by the staph epidermidis. MCQ, remember this? The most common organism is the staph epidermidis, and late onset is Propionibacterium acnes. P. acnes, remember this is the same bacteria which causes the pimples. Staph, why is the most common? Remember MCQ, another MCQ, because staph epidermidis happens to be the most common commensal. Commensal means this is the most common microbial organism present in a normal eye. You all have commensals, no? Organism which is present normally, which does not harm the body in that particular. Okay, so the most common commensal in the eye is staph epidermidis, and this is the most common cause of infection in endophthalmitis. Okay, for acute onset or early onset, late onset endophthalmitis is Propionibacterium acnes. And remember, endophthalmitis, what is the drug of choice? You have to give intravitreal, you have to give, because infection of the vitreous cavity, so we will have intravitreal antibiotics you'll have to give. For most of we give vancomycin. Okay, vancomycin is the drug of choice because these are mostly gram-positive infections. So vancomycin is drug of choice, and if it's gram-negative, that's rare, but it can happen, then you give amikacin or ceftazidime. And for late onset endophthalmitis, this is not very common, but can seen after 6 weeks. It is called as Propionibacterium acnes. And now, ladies and gentlemen, it's about an hour and a half. We have done 2 points. It's time for a short break. 10 minutes, we'll be back again, and when I come back, I'll take your questions. Okay. Meanwhile, take 10 minutes off, and we'll come back in 10 minutes live. Yours truly, Sashwat. Hi friends, welcome back to YouTube Online Ophthalmology RR on Dr. Bhanu Prakash's channel. Hope you are enjoying yourself learning also something. Hope you've had a break, a caffeine break, which is solely required. But don't worry, I'm not going to take it very long. Today around 9:15, and tomorrow the session starts about 11 o'clock because I find that it becomes very tiring for you, and not to say me, of course. Okay, we'll take it short and sweet. Okay, I hope you will. Now, a few questions which I'm getting. So, first about the PDF, the annotated PDF. The annotated PDF will be available to you after the class on Dr. Bhanu Prakash's Telegram channel, the annotated one. Okay, that will be uploaded tomorrow. Okay, that's the first question if you're worried about it. And this PDF, you're already getting it. And then another question which I'm getting repeatedly is, yes, I will do how to solve numerical questions in refraction when we do it tomorrow, so don't worry about that. Third question is one repeat question I'm getting it is that what is the treatment of choice in a very old patients with NLD blockage? So that's not a bad question. So sometimes if for 60-year-old, 60 or 70-year-old patients, we have difficulty doing DCR. So we do something called a DCT, dacrocystectomy. Okay. So what we do, we don't connect the dacrocyst to the nose. Okay, rhinostomy we don't do. We do dacrocystectomy because they're very old, 60, 65, 70, and we just get rid of the dacrocyst, which is a lacrimal sac. We just take it out. It causes a lot of watering, but that's okay because DCT is easier for the patient to handle. So remember, in a very old patient who has fibrotic, mostly the lacrimal sac is usually fibrotic or sometimes even tumorous, we just call DCT, dacrocystectomy. That is a better choice than DCR, which may have complications later on. Okay, so that leads to the question which I've been umpteen times again and again. And then another question is that, and it will be first NLD blockage, numerical questions regarding the refraction is correct. And so we've got most questions here done. So, and in oil drop cataract, there's a question I've just got, which is oil drop cataract, so you need it or not? Well, that depends on the vision. Sometimes the oil drop cataract needs to be removed. Sometimes we can let it be because the child is too small. So it depends on the vision. So you will get that question, that vision is poor, we'll take it out. Okay. And then what about anti-capsulotomy? There's a question anti-capsulotomy, which I told you that what happens, when you want to remove the cataract, see, this is the cornea, this is the capsule, and you have a cataract here inside like this. Now, how do I take the cataract out? You have to take it out. The cataract is enclosed in a capsule. So what we do capsulectomy. Okay, so capsulectomy means you remove a small piece of the capsule like this. Okay, so you can see we removed a small part of the capsule like this, and through this, we take out this cataract. The cataract was initially like this, wasn't it? So we don't remove the entire capsule. That's called capsulectomy. Now, if you remove the entire capsule, then you cannot place an IOL because there's no place for the IOL to stay, is it not? So for the intraocular lens implantation, what we do is we just take out the capsule, a small opening. This is called capsulotomy. You know that otomy means make a small hole. So this is a capsulotomy. What we've done here is like this: removed a small part of the capsule and done a capsulotomy. So this capsule. If you want to take the entire capsule out, as we do it in intracapsule, the whole capsule is removed like this. So then you cannot implant the IOL. You cannot implant the IOL because there's no space. So there's no place to put an IOL. I can't put the IOL on top of the vitreous, not. So that's what it is. So this is called capsulotomy. And what about the Nd:YAG capsule? That's different. Nd:YAG capsulotomy is different because what we do in that is you have got a secondary cataract. See, this is the capsule, this is the intraocular lens here, and what you have, a secondary cataract, is you've got a thickening here, okay. So this is blocking the rays of light. This is the secondary cataract, which is Elschnig's pearls, the Sommering rings. You can see the rays of light are getting blocked by this, So this is a patient who's very irritated. He comes back to you after cataract surgery within 6 months or 8 months or 1 year and says, "Doctor, what have you done? I can't see again. Initially I could see, but because development of secondary cataract, the rays are blocked again." So this is called blurring of vision after cataract surgery. Is called a secondary cataract. So what we do, we take a laser beam, and this laser beam is Nd:YAG laser. This laser focuses the rays of light right on that thickened capsule here, and it cuts that area of the capsule. It's called a secondary capsulotomy. Okay? Remember, the property of a laser is that when you focus it on certain thing, it will damage only that particular tissue. It will not damage the tissue that it passes through. So as you can see, the laser passes through the cornea. It does not damage the cornea. It passes through the IOL. It does not damage the IOL. It only damages the area on which it focuses. This is the capsule. So what it does, it removes this part of the capsule like this. Okay, see, it removes. This is called capsulotomy. So now you can see we remove this little area of the capsule like this. And along with this, the secondary cataracts also got rid of. So now the rays of light can focus on the retina perfectly. Okay. This is the principle of NDI capsulotomy. It's a very simple solution, a 2-minute solution for a very complex problem, which is a secondary cataract or after cataract. Okay. These are the multiple questions. And Sommer rings, and I have explained, I told you Sommer rings, we have basically 2 types of secondary cataracts. Okay. One is the Elschnick's pulse, which you saw here, or is the, I do have a picture here. See, this is what you saw here, is a multifocal. See the rings, how to recognize the multifocal IOLs. On a picture, you can see by these rings that you will see. On a monofocal IOL, which is much more common, we don't see any rings. You'll identify these rings on the IOL, and this is a multifocal IOL. And secondary cataracts, we have 2 types, Elschnick's pulse, which is more common, and Sommer rings, which is less common. Okay? Right. Then the next topic, we're back to work again, and this is the amblyopia. Let's look at amblyopia. In the last years, remember, have been asked very commonly. The amblyopia, the other name is called as lazy eye syndrome. Okay, LES, kind of remember, and it is a very common condition amongst young people. So many of you are watching this video who are, I'm sure, will be amblyopic. Okay, what is that? Let's look at that. It's a loss of vision in children due to prolonged visual deprivation. Okay. So how much loss of vision? Usually more than 2 lines. That means in a patient we're expecting to be 6'6", the patient will be at least 6'12" or less than that. So 6'18", 6'24", 6'36". It cannot be 6'9". 6'9" is only 1 loss of vision. So that does not come in the definition of amblyopia. So it's a loss of vision in a child less than 2 lines, okay, more than 2 lines of loss, which is not attributable to any structural defect. That means there is no cataract, there is no glaucoma, there is no squint, there is no refractive, there is nothing. And yet there is loss of vision. That is called amblyopia. So the causes, of course, there is a cause. You can't find that cause, that's a different thing. We remember these causes of amblyopia as strabismus, which is squint, is the most common cause. So these are children who have squints at birth and are not able to see clearly, okay, and they develop amblyopia. So this is the #1 cause of amblyopia. Remember, a lazy eye is a patient who had squint in childhood and is not able to see clearly. Okay. Second is refractive error. Refractive is uncorrected refractive error. So suppose you needed glasses when in childhood there, but you did not wear glasses. The rays of light are not focusing on the retina, so you would lose vision again. This is uncorrected refractive error. Remember, these are mostly hypermetropes. These are plus powered wearer glasses. Okay. Remember, so there are many of you who do not wear glasses, and when you should have worn them right from childhood onwards. Okay. And these are plus powered glasses. And now when we give you glasses, you will not improve. Okay, this is called hypermetropia. And the third one is some organic errors like cataracts and ptosis and all. Because the cataract is blocking rays of light, so rays of light are not focusing on the fovea. The rays of light are not focusing on the fovea. Child develops amblyopia or lazy eye because the fovea somehow forgets to see it. It becomes lazy. Because rays of light not focusing on the fovea, fovea forgets how to see it. This is the lazy eye development that you have. So these are the 3 multiple causes of loss of vision amblyopia. So the critical development, remember, is 8. So though some of you remember how to diagnose amblyopia in your case. Suppose there is a patient amongst you, suppose there is some student amongst you whose vision is 6/6 in one eye, but the other eye is 6/18. Okay. Now, when I check his eye, I find there is nothing. There's no cataract, there's no glaucoma, there's no squint, there's no refractive, there's nothing. The eye is absolutely normal. And yet the vision is poor. This is called amblyopia. Remember, not attributable to any structural defect. Do you understand? So this is amongst you, there will be at least one of you who has poor vision for which there is no cause. No cataracts, no glaucoma, no refractive error, no squint, no detachment, nothing. So then what is the cause of loss? That is amblyopia. So then we have to find out, we have to go into your childhood of the child, of the patient. Okay. So, and then we find out, well, maybe the child had cataract at birth, maybe he had squint at birth, maybe he had refractive error for which he did not wear glasses, and that is the cause of amblyopia. Remember, the most important thing to remember is amblyopia occurs up till 8 years of age. 8 years of age, after that doesn't come. So this student, this hypothetical student who's sitting amongst you, who has 6/18 vision, amblyopic, it means he became amblyopic in the first 8 years of life. You cannot develop amblyopia now, okay? So at this age, after 8 years of age, you cannot develop amblyopia. But unfortunately, after 8 years of age, you have no treatment also. So this is called the critical phase because amblyopia occurs before 8 and the treatment is also before 8. Okay, so amblyopia lazy eye syndrome is that. So the problem is that after 8 years of age, we have no improvement of visual acuity after correcting visual disorder. A very famous phenomenon is called the crowding phenomenon. Crowding phenomenon means what? Crowding phenomenon means that when you present stimuli to this child or this patient in a crowd, he will not be able to see it. But when you present this as a single stimulus, you'll be able to see. So supposing you have these, you present these letters, the fourth line, VOXT, okay? There are letters, 4 letters in the fourth line of the Snellen's chart. When you ask him to read it, he won't be able to read it. But suppose you block out these 3, you close the other letters and present only the letter V to him, the patient will be able to read it, okay? This is called as crowding phenomena. That means in a crowd or a clutter, patient is not able to see, but present as a single stimulus, the letter V or the letter O or the letter X or T as a single stimulus, they will be able to see. This is called crowding phenomena. This is a very important property of amblyopia. And what is the treatment? Remember, treatment is only up till 8 years of age, I told you. So I'm sorry to say that if any of you amblyopia right now watching me, we have no treatment for you. We cannot treat amblyopia after the age of 8 or maximum 10 years. Maximum 10 years, after that we can't treat. So I'm so sorry, if anybody amblyopic here, we can't do anything for you. Okay? But before 8 years of age, what we would do, we would close the eye. Occlusion means close, look at that. In this child, we can see we close the eye for 6 to 8 hours in a single day. Okay? 6 to 8 in a single day, every day for 6 to 8 hours, you close the good eye, remember. This is the amblyopic eye, this is the normal eye, we close this like this, and we force the bad eye. The bad eye, the poor eye, the amblyopic, we force the bad eye to develop fixation on those 6 to 8 hours. You see, because if I did not close the good eye, the child would never recover vision in the bad eye. He would only see with the good eye. Forcing the good eye close forces the bad eye to develop fixation. And this takes about 6 months, 8 months of occlusion and maybe 1 year, but they get very good vision. But only till 8 years of age. Sometimes the child resists occlusion. You see, we have to close the eye with a patch or a bandage like that. The child resists that because he doesn't see with the other eye, he's amblyopic in the other eye, and he cries and pulls it off. In that case, we do penalization. Penalization means punish. We put a drop atropine, weekend means only Saturday, Sundays, we put atropine, only Saturday, Sunday in that eye, that causes blurring of vision in the good eye. Again, the good eye. Amblyopia occlusion, remember, is always done in the good eye. We close the good eye so that we force the bad eye to develop fixation. So we can put, remember, the drug of choice is atropine, which causes blurring of vision. So the treatment is actually occlusion is better, but suppose children don't want occlusion or they resist occlusion by crying excessively, pulling the bandage off, then we can penalize them. Penalize means we punish the good eye. Punish the good eye for being too good. So don't be too good, okay? Too good, we often punish you. Remember, of late, so amblyopia has been asked quite a bit, so you have to be careful about amblyopia because in the last 2-3 years we have been asked amblyopia. So again, to summarize, okay? So suppose you have any of my students, you have one eye 6/6/18 at which you are sitting right now. If I find that 6/18 is there, but the eye is absolutely normal, no cataract, no glaucoma, no detachment, no squint, no refractive error, that means amblyopic. So then I look into your history. I delve your history when you were a kid. Before you do, did you have refractive error, not wear glasses? Yes, that is the cause of your amblyopia. Did you have squint for which you did not get corrected? Yes, that is the cause of amblyopia. Did you have a ptosis which was uncorrected? Yes, okay, that caused loss of vision. You understand? So anything that causes loss of vision in a child during the first 8 to 10 years of age. Why this particular 8? Because that is called the plastic age. The brain is highly plastic and is able to form new influences. The plasticity of the brain means that a brain can adapt to new influences, new change. So in that particular critical period, if images are not forming on the brain, so it becomes amblyopic. Okay, so that is why after 10 years of age, we cannot, the brain is no longer plastic, is not able to adapt itself to new images, new memories, new stimuli. So that is why there is no treatment after 8 to 10 years of age. Okay, so be very careful about this. The most common cause is uncorrected squint, uncorrected refractive error. So one more question I would like to ask you, which they love to ask you, is, suppose the question is a 5-year-old child has 6/60 vision, okay, and when we give what is the cause of loss of vision? It is refractive error of +3. When you give him +3 diopter sphere, the vision should become 6/6, but does not become 6/6. It becomes 6. It still remains 6/6. Okay. So again, see, two children. Suppose both of them are 5-year-old kids. Both of them have poor vision, 6/60. Both of them have 3 diopters difference. Okay. They need glasses. Remember, the patient A is a hypermetrop. He needs +3. Patient B is a myop. He needs -3. So when they come, they have both of them, remember, 6/60 vision. When they come to me, I give them both glasses. But when I give it to -3, vision improves to 6/6. But when I give it to +3, vision remains 6/60. This vision, which goes to 6/6, is the refractive error. So if the vision improves with glasses, it is a refractive error. If it does not improve, it is amblyopia. Okay, remember, it is only amblyopia when, despite correcting the refractive error, the vision does not improve. So you give glasses, it doesn't improve, amblyopia. You correct squint, vision does not improve, amblyopia. You do cataract surgery, vision does not improve, amblyopia. Okay? If it improves, then the diagnosis is the cataract or the squint or refractive error. If it doesn't improve, it's amblyopia. Why doesn't it improve? Because the brain has forgotten how to see. Okay? So kind of remember, amblyopia is a very important topic. We get a lot of questions on amblyopia, and children become amblyopic primarily because they don't come to us. Okay? Very well. So we go to now, we finish cataracts now. We go to another important topic called uveitis, inflammation of the uvea. Okay. So this is the inflammation of the uveitis. Remember the uvea, if you remember the uvea, what is iris, ciliary body and choroid. Okay. Remember there are 3 things: iris, ciliary body and choroid and uvea. So inflammation of any of this or all of them is uveitis. So if the iris gets inflamed, we call it iritis. The choroid gets inflamed is choroiditis, and ciliary body gets inflamed, we call it cyclitis. Remember, the word cyclo refers to ciliary body. And if all of the 3 gets inflamed, we call it as pan-uveitis. So there are 4 types of uveitis. Okay, pan means the whole thing is there. The anti-uveitis is if the iris or the ciliary body gets inflamed. Okay, iris or the part of the ciliary body which is the pars plicator. Intermediate is when the pars plana and the vitreous gets inflamed. This is called intermediate uveitis. And posterior uveitis, as you can see the diagram here. See, the diagram tells you, see, this is the iris. When this gets inflamed along with the part of the ciliary body, this is the pars plicator. This is called as anti-uveitis. So it can be plain iritis or it can be iridocyclitis. Second is intermediate, if this is the pars plana and this is the vitreous here. Okay. So if the pars plana and the vitreous both get inflamed because they are in continuation with each other, this is called as intermediate uveitis. This is intermediate uveitis. And the third is posterior uveitis. If the choroid gets inflamed, this is called as choroiditis, also called as posterior uveitis. So it depends on the anatomy, which part of the eye gets inflamed. Okay, this is the inflamed, and this is anterior, intermediate, and posterior uveitis. And if the whole thing gets inflamed, remember, whole means pan, called pan-uveitis. So let's discuss this. And in uveitis, apart from this classification based on anatomy, we have another class which is called acute uveitis and chronic uveitis. Acute uveitis means uveitis which lasts less than 3 months, and chronic uveitis which lasts more than 3 months. Any uveitis lasting more than 3 months is called as chronic uveitis. Anything less than 3 months is acute uveitis. And then one more classification we have to know. What is that? It's called granulomatous and non-granulomatous uveitis. Granulomatous uveitis means uveitis caused by any disease which form granulomas like TB, syphilis, sarcoid, Lyme disease, etc. So that is called granulomatous uveitis. So these are not very common. They're dangerous, but luckily they're not very common. Okay, much more common are called non-granulomatous uveitis. So they do not form granulomas. So kind of remember, when we write diagnosis of uveitis, we have to write the full form, whether it's acute or chronic, whether it's anterior, intermediate, posterior, or pan, whether it's granulomatous or non-granulomatous. Okay. So the full description of uveitis would be something like this. You can write as acute, anterior, non-granulomatous uveitis. Okay. So this is the full. This is an example of a kind of uveitis we did. Now, so what is of this lot? Remember, the most common is this one called as anti-uveitis. This is the most important. Why it's most important? Because it's the most common. Almost 70% of all uveitis is anti-uveitis. So anterior part of the iris gets the most inflamed. Anterior part of the iris and the pars plicator is anti-uveitis. And Then anti-uveitis is the most common, 70% I told you, and the most common cause is idiopathic. Remember what is idiopathic? Idiopathic means that there is no known cause. So there's no known cause. We don't know why. Almost 50% of all anti-uveitis, we don't know any cause. So this is the single most common cause. But we don't ask you questions of idiopathy. Idiopathy is nothing to ask. So what is the second commonest cause of anti-uveitis? Are certain diseases which are linked to this particular group of antigens called the HLA-B27. Okay, this is called the HLA-B27. Remember, the HLA full form is human leukocytic antigen. Okay? So this is an antigen which is present in the blood, and people who have HLA-B27 positive, you have to do a test for that, they have these 4 types of spondyloarthropathies. Look at that. Spondyloarthropathies means disease of the spine and the joints. So there are people who have their disease of the spine and the joints, and there are 4 of them: ankylosing spondylitis, IBD, ulcerative colitis, and psoriatic arthritis. Okay, so remember that these are 4 diseases which occur to people which are HLA-B27 positive. Okay, so HLA-B27 positive will have a higher chance of developing these 4 diseases, and these diseases, they can cause anti-uveitis. So the number 2 cause of anti-uveitis, remember, is this one called ankylosing spondylitis. Can you remember this? This is a disease very commonly in our country, and it has 3 characters. It is found in young males which are tall and thin. Okay, so remember, tall, thin, young males. Okay, many of which are my students. So tall, thin, young males who have chronic low backaches. Remember, any of you who are tall, thin, and young males and have chronic low backaches, you have to see a doctor. You could be ankylosing spondylitis. The ankylosing spondylitis occurs, and this causes the second most common cause of anti-uveitis. Okay, so remember, this MCQ often asked that a young male with low backaches presents to you with red painful eyes. A young male with low backaches presents to red painful eyes. Remember these ankylosing spondylitis and the red painful eyes telling you they are causing anti-uveitis. Okay, so this is the second most common after idiopathy. Then IBD, inflammatory bowel disorder, remember, consists of 2 diseases: either Crohn's disease, or ulcerative colitis. There are 2 of them, and they are seen in young ladies, usually middle-aged young ladies, 30s, 40s, and IBD also cause anti-uveitis. So typically with this MCQ often asked that a 40-year-old lady comes to you with bloody stools and red painful eyes. Look at that. Bloody stools in combination with red painful eyes is a combination of anti-uveitis with inflammatory bowel disorder. So please remember, bloody stools and red painful eyes means it is IBD causing anti-uveitis. Third type of disorder, HLA-B27 positive, have the psoriatic arthritis. So these have psoriasis and they have arthritis, and they also cause recurrent anti-uveitis. Fourth is reactive arthritis. Reactive arthritis, remember, is a classic triad of CUR. Remember, conjunctivitis, urethritis, and arthritis. So these are also found in young males. Remember, so typically MCQ asked, a young male comes to you with urethritis and arthritis, okay, and has red painful eyes, you will say it is reactive arthritis. How to diagnose it, remember, is that reactive arthritis occurs only in young males. But young males have urethritis. You all know that males usually do not have urethritis. Urethritis is normally seen mostly in females because of the shorter length of the urethra. So whenever you see a young male with urethritis and arthritis, your mind should jump to that it might be reactive arthritis. Okay, simply because it is very rare to have urethritis in males. So we have these 4 different causes of HLA-B27. This is the typical 4 types of uveitis they can cause this thing. Then another important cause is the famous JRA. Okay, this is called juvenile rheumatoid arthritis, also called as juvenile idiopathic arthritis. Okay, so now the older term was JRA, juvenile rheumatoid arthritis. Now it's called JRA. Remember, it is the very common cause of uveitis in children. It is in fact the most common cause of uveitis in children. In adults, it is idiopathy. In children, it is JRA. And these are children with joint pains. Remember, it's not the same as rheumatoid arthritis. Remember, these are small children with joint pains, and they develop uveitis again and again throughout life. Okay? So this is the most common cause of uveitis in children. So these are multiple causes of questions, and once we have done the cause of uveitis, let's look at how we diagnose it. See, the first and very important thing is the famous circumciliary congestion. These patients have anti-uveitis presents to us with 3 things: pain, redness, and loss of vision. Okay? pain, redness, and loss of vision. These are the three causes, the three presentations. So typically, the patient wakes up with pain, redness, and loss of vision. And remember, it's called circumciliary congestion. What is that? Congestion is redness, and it is called circumciliary. You can see that the word circumciliary means around the ciliary body. To see this redness all around the cornea or also the ciliary body, this we also called as circumciliary or circumcorneal. Okay, so you typically it is a pinkish red. It's a bluish red color, which is very obvious on examination, and it will surround the entire cornea like this. This is called circumcorneal or circumciliary congestion. Okay, then this is one of the major important findings. But the hallmark of anti-uveitis is the presence of cells. What are cells? Cells are white blood cells or neutrophils in the anterior chamber. Okay, these are white blood cells or neutrophils in the anterior chamber, and they keep moving up and down. Okay, normally there are no white blood cells in the anterior chamber. So when you have a lot of white blood cells, then you have a lot of, that means that you have cells here. Cells is a very important marker of activity. Activity means that the uveitis is active and needs to be treated. Then flare. The earliest sign, remember MCQ is earliest sign of anti-uveitis is flare. Flare is seen as a beam of light passing through the aqueous humor. Okay, you will see when you put it on the slit lamp, you will see a beam of light passing through the aqueous humor. This is called flare. Okay, so this is the early sign of anti-uveitis. Then certain signs called KPs. KPs are keratic precipitation. Remember the word KPs. Keratic means cornea. So whenever you have the word keratic is used, it means cornea. So what happens? You have these cells. These cells are neutrophils moving up and down in the anterior chamber, and when they get stuck to the cornea, because they're very sticky, they get stuck to the cornea. They're called KPs. And because they settle down at the bottom of the cornea, remember, because of gravitation currents, they settle down at the bottom of the cornea, and that's why KPs are seen in the inferior half of the cornea in the shape of a triangle. Very important MCQ, please remember, it's called as Arlt's triangle. This is called as Arlt's triangle. This is the famous triangle. So you will see it's something like this. So you will see the cornea like this. On the Arlt's triangle, the inferior triangle, inferior area in the cornea, this is the KPs get stuck here. This is called the Arlt's triangle. It's a very peculiar triangle which you can see in the inferior half of the cornea, called Arlt's triangle. Okay, then a special type of a KP which you must remember is called a mutton fat KP. A mutton fat KP, what is that? A mutton fat KP is a KP only, but it is like mutton. It's large and oily and greasy. Okay, it looks like mutton fat, and that is why it is a sign of granulomatous uveitis. You must remember, I told you granulomatous uveitis means uveitis caused by either TB or leprosy or syphilis or sarcoidosis. Is it not? So this is a typical sign. They are large and oily and greasy. It's called mutton fat KPs. Remember MCQ, the most common type of a granulomatous disease causing anti-uveitis is sarcoidosis. Always remember, never forget that. Okay, the most common granulomatous disease causing anti-uveitis is sarcoidosis. And then you have Kopis and Bisacca's nodule. Remember, Kopis has double P. So these are nodules on the pupillary margin. Okay, on the pupillary margin, you have small nodules like this. Just remember P to remember Kopis nodules. And Bisacca has an S, so they are on the surface of the iris. S for surface of iris. So these are nodules both on the iris. If they are on the surface of the iris, remember the S for Bisacca, it's called Bisacca's surface. If they are on the pupillary margin, we call P Kopis nodules. Both of them are signs of granulomatous uveitis. Remember, in granulomatous uveitis, you can have mutton fat KPs, you can have Kopis nodules, you can have Bisacca's nodules. You can have any one of them, you can have all of them, but the most common are the mutton fat KPs. Remember, mutton fat KPs are always seen, mostly seen in granulomatous uveitis. Another powerful sign of uveitis is the famous festooned pupil. What's that? A festooned pupil, remember, is an irregular pupil like this. You see, the normal pupil is regular, but a festooned pupil becomes irregular. Why? Because the sign of posterior synecdoche. You see, look at that. Why? So this is the iris, and the iris is very sticky because of inflammation. So it can either get stuck to the cornea like this, called anterior synecdoche, or it can get stuck to the posterior structure, which is the lens. If it gets stuck to the cornea, we call it anterior synecdoche. Okay, anterior synecdoche. Synecdoche means adhesions. Okay, the holding together. And it can block the angle, so anterior synecdoche may lead to glaucoma. Because the angle is blocked, the aqueous cannot get out. Okay, but also it can attack the lens. Also, it can touch the lens, and this is called posterior synecdoche. And as soon as you get a posterior synecdoche, you develop cataract. Because remember, the lens is absolutely transparent, and the minute the iris touches it, it becomes opaque. It becomes cataract. This is the complicated cataract forming. And see, normally this pupil is circular, but when the iris touches the lens, it becomes irregular like this, and this irregular pupil is called festoon pupil. Can you remember festoon pupil is a very important sign of posterior synecdoche seen in anterior uveitis. Then what about intermediate uveitis? Intermediate uveitis, remember by definitions, inflammation of the pars plana along with the vitreous. So it's pars planitis with vitritis. And the most common cause is again idiopathic. We do not know the cause. Again, cause idiopathic. And second commonest cause is sarcoidosis. Remember, sarcoidosis, can you remember I just told you, is the most common granulomatous disease causing uveitis. Remember, sarcoidosis can cause all kinds of uveitis, anterior, intermediate, posterior, and pan. But if asked which is the most common type of uveitis, you will say sarcoidosis causes most commonly anti-uveitis. It causes most commonly anti-uveitis. So, but it can also, so intermediate is the most common cause here after idiopathy. Remember, idiopathy we don't usually ask you. Then sometimes you have loss of vision. Normally, remember, posterior intermediate uveitis has only these things called floaters. They are mostly floaters, which are black objects floating in front of the eye. They are called floaters. But sometimes you have loss of vision. In intermediate uveitis, sometimes you have loss of vision. This is called loss of vision. This is due to cystoid macular edema. It's called CMA. Remember, CMA again makes its appearance. I told you cystoid macular edema occurs cataract, and here CMA occurs after anti-uveitis. In intermediate uveitis also, this is called CMA. But the most important MCQ of intermediate uveitis is the famous snowballs and snowbanks. Okay, and remember that because there's inflammation, so these neutrophils, they collect on the pars plana like this. Okay. And because they're white in color and round in shape, so they look like snowballs. They look like snowballs. And the entire collection is called a snowbank. Okay, the entire round in shape, and it is it's completely full of this thing. The whole thing is called a snowbank. So very important MCQ. Where would you see snowballs and snowbanks? Remember, in intermediate uveitis. Okay, and then what about posterior uveitis? Posterior uveitis, which is also choroiditis. The most common cause, these are infections. Remember, they are not idiopathic. Unlike anterior and intermediate uveitis, which are idiopathic, the most common posterior uveitis are infections. And the most common infection, kindly remember, is toxoplasmosis. MCQ, very important. Remember, toxoplasmosis is the single most common cause of posterior uveitis, and it is got from cats. Okay, so remember, those of you who are fond of cats, you might get toxoplasmosis. The number 2 cause of posterior uveitis is tuberculosis. Okay? There are 2 infections which cause posterior uveitis. Mostly they are infections only. Okay, non-infectious are also there, but they are rare causes like sarcoidosis. So tuberculosis, can you remember, is the second commonest cause of posterior uveitis, and this has a very important MCQ. What is that? Remember, the tuberculosis attacks the eye in multiple ways. It can attack the eye in 10 different ways, but the most common cause is posterior uveitis. So this question is often asked: what is the most common ocular manifestation of tuberculosis? Ocular manifestation of tuberculosis, remember, is posterior uveitis. So TB can attack the eye in multiple ways, but the most common way it attacks is posterior uveitis. Then what about when you have toxoplasmosis? Remember, there's a very famous appearance. See, the entire vitreous becomes hazy. You can see the picture here. Can you see that? The picture is very hazy. And because it's hazy, so it's typically called headlight in fog appearance. The fog is the haziness which you see, which is caused by the vitritis, and the headlight is this thing which you see is the toxoplasmosis lesion. Okay, so very famous appearance. Can you remember? Headlight in fog appearance is the description of posterior uveitis caused by toxoplasmosis and only toxoplasmosis. Okay? And sometimes, you know, you get another question which is more of an advanced question. You get this word called punched out retinal scars. You know, punched out retinal scars is what you see. Can you see this black thing here? This thing here, this is like a punch, you know, like a punching. You have seen a punching machine. So when you have posterior uveitis which is healed or a older toxoplasmosis, so you often on the retina you will get these absolutely punched out lesions which looks as if created by a absolutely circular, like a clean cut. This is called a punched out scar, and this is a sign of old toxoplasmosis. Remember, the toxoplasmosis, we can ask 2 questions, and we do ask this. Sometimes we give you punched out retinal scars. That's also toxoplasmosis. Older ones and the fresh ones are called as headlight and fog appearance. So this is about posterior uveitis. So we have done posterior uveitis, the 3 different kinds: anterior, intermediate, posterior. Remember, anterior uveitis and intermediate are mostly idiopathic. Posterior uveitis, toxoplasmosis, followed by tuberculosis. And then what about sympathetic ophthalmitis? Sympathetic ophthalmitis. Okay. Sympathetic ophthalmitis is a type of pan-uveitis. Okay, this is pan. Remember, we've talked about pan-uveitis, which means the entire uvea is inflamed. Okay, the entire uvea is inflamed. Okay, the entire iris, ciliary body, and choroid, the whole thing is inflamed. So this is called pan-uveitis. This is, of course, the most dreadful, the most dangerous, and the rarest kind of. It's also, luckily for us, rare. Okay, so let's look. This sympathetic ophthalmitis is an example of pan-uveitis. It is very dangerous. Look at that. What is it? It's a bilateral granulomatous uveitis. That means both eyes are inflamed. It's granulomatous and it follows trauma to one eye. So see how sympathetic ophthalmitis is different from the other kinds of uveitis. How it's different from other kinds of uveitis? First, it is bilateral. Okay, remember all other uveitis is unilateral. This is both eyes. Second, it is granulomatous uveitis. That means it behaves the same way. It has granulomas like TB, leprosis, syphilis, and sarcoid. And third, it is due to follow trauma to one eye. What happens? You get trauma to one eye, but both eyes get inflamed. Then be careful. Trauma is to one eye, but both get inflamed. That is why the injured eye is called the exciting eye. Remember, the injured eye is called the exciting eye, and the other eye, which is perfectly normal, which is sitting quietly, not doing anything at all, and yet gets inflamed, is called the sympathizing eye. Okay? It's called the sympathizing eye because it is sympathizing with the damaged eye. Okay? So we have two things. One is called the exciting eye, which is the injured eye, and the other eye, which is not doing anything but gets inflamed and damaged both, is called sympathizing eye. That's why it's called sympathetic ophthalmitis, because it's sympathizing with the other eye. And then this, what about this trauma? This trauma has to be very specific. Okay, it cannot be a blunt trauma. It has to be either penetrating or perforating trauma. Okay, what is that? Penetrating means an injury which enters but does not exit. Okay, there's not enough force to carry it out. The enters but stays there, does not get out. And perforating is through and through. So remember the difference? Perforating is through and through. This is perforating through and through injuries. And also remember that injuries, this the most commonly seen to the ciliary body. Very important to remember, ciliary body has the highest incidence of causing sympathetic ophthalmitis. So ciliary body injuries have the highest incidence of causing sympathetic ophthalmitis. So it is also called the dangerous area of the eye. Why? Because ciliary body injury has the highest chance of getting providing injury causes the sympathetic ophthalmitis. Also called the dangerous area. Ciliary body is called the dangerous area of the eye. And then most commonly remember, sympathetic ophthalmitis seen within 2 weeks to 3 months after injury. That means suppose my left eye injured, the right eye will develop sympathetic ophthalmitis within 2 weeks to 3 months of injury. This is the most common time period. 50% of sympathetic ophthalmitis occur within 2 weeks to 3 months of injury. You can count after that also, but it's not very common. So you can remember this critical period, 14 days to or 2 weeks to 3 months of injury. And you have to remember one particular famous finding here called the DFN, Dalen-Fuchs nodules. Okay, remember DFN. This is an important trick. See, I am giving you an important hint. Sometimes when you have to memorize something, you find it easy to memorize if you just remember the initials. Instead of remember Dalen-Fuchs nodules, suppose you just remember DFN. It makes life easier sometimes. So Dalen-Fuchs nodules are nodules on the choroid, and they can be seen in the sympathetic ophthalmitis. And because the granulomatous uveitis, so you will see mutton fat KPs also in sympathetic ophthalmitis. And the most important question is the famous retrolental flare. What is that? Behind the lens, you develop, because retrolental means behind the lens. So behind the lens, you develop this flare, which is called retrolental flare. Kindly remember, this is the earliest sign of sympathetic ophthalmitis. Very dangerous, and always asked what is the earliest sign of sympathetic ophthalmitis. The other eye is getting dangerously inflamed is called retrolental flare. And the best question, the most important is that supposing you have one eye injured, okay, so that is PL negative. That means there is no useful vision in this eye, PL negative, okay, and the second eye is 6/6, okay. So he comes to, why does he come to you? Because the second eye is now developing signs of inflammation. So he develops photophobia, he develops accommodation failure, and you can see the retrolental flare and the granulomatous uveitis, which is mutton fat. So you know that this patient has had injury to this eye, this is the exciting eye, and this is sympathizing. So what do you do? The best treatment here is to take out this eye, enucleate, remove this eye. Why? Because first, it has no vision, so there's no loss, and second, if you remove this eye, then you take out the antigens also. These antigens are responsible for producing the antibodies which attack the other eye. If you take out the eye, which is no vision, you take out the antigens, so there's no further antibodies. The antibodies cannot attack the other eye, so there is no sympathetic ophthalmia. But remember, it has to be taken out within 2 weeks. That's an MCQ. What is the critical period for taking out the eye, which can prevent sympathetic ophthalmitis of the other eye, is 2 weeks. Okay, if you take it after 2 weeks, then it will not help. Okay, so this is the dangerous sympathetic ophthalmia, which we are very scared of, because one eye is injured, but both eyes are lost. Remember, it is the single most dangerous condition in entire ophthalmology, because in this case you can become bilaterally blind. Okay? You can become bilaterally blind. So this is sympathetic ophthalmia. This is the example of pan-uveitis we can do. And the next thing we need to do, is ocular manifestations of HIV. Is what are the ocular manifestations? If HIV, suppose develop AIDS, then what will happen? If you develop AIDS here, then what will happen here is that, what are the conditions? Now here, that's a very important question, because AIDS or HIV is a very important combination of questions for us. Remember, here, the most common ocular manifestation of HIV is called cotton wool spots, also called as soft exudates. You have to remember this. You can see this picture here. This is the soft exudates that you see here. Okay, soft exudates here. And the soft exudates, they are also called cotton wool, because that's what they look like, balls of cotton wool hair. The balls of cotton wool hair. Remember, this is also called as microangiopathy. Why? Micro is small, angio is blood vessels, pathy is damage. So what happens? The earliest manifestation of HIV2 occurs in the retina, where the small blood vessels of the retina get inflamed. Microangiopathy. So when the small blood vessels of the retina get inflamed, they produce these soft exudates, which are also called as cotton wool spots. Remember, they are the earliest and the most common manifestation of HIV. But the vice versa is not true. What does that mean? It means that vice versa is not true. It means that they may be the most common presenter of HIV, but HIV is not the most common cause of soft exudates. So whenever you see soft exudates on the retina, your first diagnosis is not HIV, because they are seen more commonly in diabetic retinopathy and hypertensive retinopathy. Okay, so remember, if you see soft exudates in a patient, don't jump to the conclusion that he has HIV. No, first you rule out the diabetes and the blood pressure, because they are more common, and then you think of HIV. Okay? Then a very important question is the most common ocular infection. The most common ocular infection of HIV is called as CMV retinitis. Please remember, this is not a very rare infection. It's not a very common, it's not a very common infection, but when you see it, it means that there is underlying HIV. Okay? So please remember that CMV retinitis is the most common ocular infection of HIV, and it appears this very colorful picture. Can you see this red and yellowish picture? This typically, it's called a pizza pie appearance. Very famous pizza pie, because this red and white appearance. Red is the hemorrhages that you can see, and yellow or white is the necrotic patches of retina. It's often called a pizza pie appearance. There's a very dramatic picture, and whenever you see it, you should identify this as CMV retinitis, because red and white is the famous. We call it the tomato ketchup appearance. Sometimes we call it the scrambled eggs and tomato ketchup appearance, where it looks like scrambled eggs and tomato ketchup. Sometimes we call it the pizza pie. Okay? Ophthalmology is full of lovely terms for horrible conditions. Then you have the most common systemic infection of HIV. Remember, the most common ocular infection of HIV associated is CMV retinitis, but the most common systemic infection is tuberculosis, which also kills and is the most common cause of death in HIV patients. However, the most famous question asked is, what is the most common tumor, ocular tumor associated in HIV, is the famous Kaposi sarcoma. Okay? Kaposi sarcoma is normally a very rare infection, but this is very commonly seen in HIV, okay, because of the lack of immunity. HIV suppresses the immune response, so a lot of rare and infections and tumors which are not commonly seen, they are spring up. Okay? So kindly remember, Kaposi sarcoma is the most common tumor of the eye in HIV. Okay? So multiple questions of HIV, and one more we like to ask. See, nowadays the commonest treatment for HIV, as you know, is heart therapy. You all know that. Highly active antiretroviral therapy. No? This is a combination of 3 drugs. It's a cocktail of 3 drugs. Highly active antiretroviral therapy is a combination of 3 drugs which we use in HIV. Remember, we have an important side effect. When we use this drug, the patient starts improving, But also paradoxically, his eye appears to be more worse. It appears more inflamed, it becomes red, it has more cells, it has more hypopyon, and you may have CME. So this is called as immune recovery uveitis, IRU, immune recovery uveitis. You understand? This is the most common ocular side of heart therapy. Paradoxically, eye seems to worsen. It's improving, but seems to. Why? Because as the drugs take place, the recovery starts, because the immune recovery starts, and this immune system now attacks the HIV, causing more inflammation. Previously, there was not enough immunity to attack the infection. Now there's enough immunity to attack the infection and cause this immune recovery uveitis. This attack, increased inflammation of the eye, paradoxically is called IRU. Be careful about this question, because it seems the patient is worsening, but actually is improving. Okay? Then, so that's about uveitis agentment. We have enough of uveitis, and now we're going to talk about glaucoma. The next condition, glaucoma, is, remember, the second commonest cause of blindness in the world. Okay? About 12% of patients suffer from glaucoma. Remember, the most common cause of blindness is cataract. It comes glaucoma. So how do we diagnose glaucoma? We have three conditions. Remember, there are three things again. Raised intraocular pressure. How much? That is more than 21 millimeters of mercury. Remember, I told you when we're doing the various numericals that the intraocular pressure varies anything from 10 to 21. Anybody more than 21 millimeters of mercury is glaucoma, has glaucoma, and this is more than 21 millimeters of glaucoma. So this is first. Second is optic disc. This raised intraocular pressure damages the optic disc. Okay, and third is visual field defects. Okay, so remember, the visual field is this area. Look at me when I look at you straight like this. So I'm looking at the camera, but while looking at the camera, I can see the other things also. No, I can see there are walls here. There is a ceiling and there's a floor. All of this which I can see while looking straight ahead. So this is my visual field. Okay, all this area that I can see around the central target is called my visual field. This visual field is an important function of the optic nerve. If you have normal optic nerve, the visual field will be normal. If you have a damaged optic nerve, the visual field will be lost. This is often asked as MCQ, which is the most important investigation for checking the optic nerve function. Okay? The most important most important examination for checking the optic nerve function is a visual field testing, which is called perimetry. Remember, perimetry is the term for visual field examination. Just like tonometry is a term for intraocular pressure measurement. When we measure intraocular pressure, we call it tonometry. When we measure perimetry, we mean visual field. So kindly remember that if your visual field is poor, it is only because the optic nerve is damaged. So look at the classic triad. You'll have raised intraocular pressure. Why? We don't know. Most of the causes are not known to us. This leads to damage to the optic disc. Why? Because the optic nerve can only take a maximum pressure of 21. And after that, it will start damaging due to compression of the optic nerve. And third, as the optic nerve gets damaged, you will have visual field damage. Slowly, the visual field collapses over many years. Okay. So out of these three, remember, you need only two. Just two are enough. You don't have no need to have all three. You can just need two, any two. No, any two. So that's why be careful. So supposing you have a condition where you have the pressure is normal, say 15 millimeters, okay, but the optic disc is damaged and the visual field is damaged. See what's happening? This means this is glaucoma. Why? Because any two out of the three, we need disc and field are damaged. Even with normal pressures, this is called normal tension glaucoma. Even normal pressures can damage the optic nerve. So it's called normal tension glaucoma, which is particularly dangerous because the pressure is normal and still there is glaucoma. But if the pressure is high, say 55, but the disc is normal, optic disc is normal, and the field is normal, remember, this is not glaucoma. The pressure is high, but the disc is normal and the field is normal. This is not glaucoma because you have only one which is abnormal, the rest two are normal. You need two out of three. So this condition is not glaucoma. This is called as ocular hypertension. If only the pressure is high, but the other two are normal, this is called as ocular hypertension. It may be cause glaucoma later on, or it may not, but right now, this is not glaucoma. Okay, so this is the raised intraocular pressure causing glaucoma and the destruction. So remember what happens as this pressure comes, it destroys this one particular cell which you must remember. This is called the ganglion cells of the retina. We call them the RGCs. The target, so kindly remember MCQ, the target of glaucoma is to destroy the ganglion cells of the retina. These ganglion cells, if you might remember, are the third order neurons. Remember I told you, or you should remember from basic ophtha, the first order neurons are the Rodgen cones, the second order are the bipolar cells, and the third order are the ganglion cells. So the target of damage is the retinal ganglion cells, and they get damaged in glaucoma. And we cause glaucoma. We have two types of glaucoma. One is called congenital from birth onwards, and adult glaucoma, which is after 40 years of age. So congenital glaucoma, the child develops glaucoma within from birth till 3 years of age, okay, usually within 3 years of age. So when we have developed till 3 years of age, remember, we call this as primary congenital glaucoma, PCG, primary congenital glaucoma. Okay, this is also called ophthalmos because it stretches a lot and it looks as big as a bullseye or a cow's eye. Okay, so that's why you see why this definition is within 3 years of age. Why not 4 or 5 or 6 or 7? Because up till the age of 3, remember, the eyeball is highly elastic and it can cause enlargement of the size of the eyeball. Up till the age of 3, highly elastic and enlarge the size of the eyeball. That's why these eyes are very large, like a bull's eye or a cow's eye. We call this as ophthalmos. Okay? So this is and the classic triad, can you remember that you can diagnose them? I mentioned this before. Remember, we're talking about nasolacrimal duct obstruction, photophobia. That means he cannot tolerate bright lights. He turns the head away like this. Photophobia and blepharospasm, tightly shut lids, eyes tightly shut, and third, lacrimation, excessive watering. Remember, that was the whole point. If the eyes are watering, it could be nasolacrimal duct obstruction also, but it could also be primary congenital glaucoma of ophthalmos. Okay, remember how to differentiate. These are highly intolerant patients. They keep their eyes closed, cranky, irritable kids. They're always crying. Okay, and why does this occur? This occurs because look at the cause. The cause is there is a membrane present right from birth onwards, the angle. This membrane is called the Barkhan's membrane. Remember the name of this membrane? See, the angle is like this. This is the cornea. This is the iris. So you have an angle like this. This is the angle it gets. So this Barkhan's membrane is present right from birth onwards here. Right from birth onwards here, and it causes obstruction of the aqueous. The aqueous cannot get out. The pressure rises, causes glaucoma. This is how the basic process. Remember, this child, the main problem is born with the Barkhan's membrane. The Barkhan's membrane does not allow the aqueous to get out, raises intraocular pressure, damages the optic nerve. This is how we have ophthalmos. And so how do we diagnose? We diagnose by the large size of the eyeball, a lot of hazy cornea. The cornea becomes hazy. So this is because the corneal edema, and the famous HAB striae. Because of the enlargement of the size of the eyeball, the cornea is stretched. As the cornea stretches, see what happens? It causes these HAB striae. Striae means folds. You can see these tracks, these parallel railway tracks like this. You can see this very clearly. They appear on the cornea. This is called as HAB striae. And whenever you see HAB striae, this is the diagnostic finding of ophthalmos or congenital glaucoma. Okay? So this is the typical diagnosis. Remember how to diagnose? It's pretty easy actually. First of all, the patient is a child up to 3 years of age who has an enlarged eye, whose cornea is hazy because of corneal edema, who has HAB striae, these parallel tracks. The intraocular pressure is very high. Compared to, it should be about less than 20, it is mid-30s, 31, 32, 35. Okay? So everything was easy to diagnose this. And what is the treatment? Treatment is basically we do goniotomy. So remember this angle, no? So this is the angle here, and this is the angle. So what if I took a needle here and perforated the membrane like this, then allow the aqueous to get out, no? So this is called goniotomy. So remember the treatment of choice of ophthalmos is goniotomy, making a hole in the angle. You take a needle and you make a hole in the angle, and this will allow the aqueous to get out. The pressure will fall down. So this treatment of choice is goniotomy in ophthalmos. But as I said before also, goniotomy is difficult to do because the cornea has become hazy. By the time he comes to you, the cornea has become totally hazy. So ophthalmos doesn't have a very good prognosis. Therefore, the next thing is open angle glaucoma. Open angle glaucoma, let's talk about open angle glaucoma. Open angle glaucoma, what is, now we divide adult glaucoma. So see, this was children glaucoma up to the age of years. Adult glaucoma is defined as anybody more than 40 years of age having glaucoma. If one glaucoma is 40 years of age, is adult glaucoma. Adult glaucoma, so we divide them into open angle glaucoma and angle closure glaucoma. Okay, we divide into open and angle closure glaucoma. The worldwide difference, remember, ratio, you have to remember that. Worldwide, open angle is 3 times more common than angle closure glaucoma. Okay, so this has been asked once. What is the frequency of open angle glaucoma? It's 3 times more common than angle closure glaucoma. Okay, let's look at open angle glaucoma. What are the risk factors? Why should you have open angle glaucoma? The pressure rises. So, but why? First of all, risk factors, family history. So, if you have a family history, your parents, your grandparents have glaucoma, then the chance of developing glaucoma higher. If you have a thin CCT, what is that? CCT stands for central corneal thickness. If you have a central corneal thin, remember there are two problems here. A thin central cornea, remember cornea is, I told you, it depends on patient to patient. You remember one of the few slides I told you, average thickness is 540 microns, I told you. But there are many patients who have thinner corneas. And when you have a thinner cornea, then the pressure, because the thin cornea damages the optic nerve more. Okay, that is one. And second, the thinner the cornea, the intraocular pressure is lowered falsely. You understand? So, supposing your pressure is 25, okay, but you have a thin cornea, it will register not as 25, but say as 15. This is because of a trick of measuring the pressure. Thinner corneas measure falsely low, thicker corneas measure falsely high. Okay, false. So, that gives a problem. Okay, suppose you have a thinner cornea, say 500 microns. So, even if the pressure is 25, because it will measure falsely low pressure, so you will see it as 15. If you see it as 15, you will think that you have normal pressure, but it is not normal. It's not normal. No? So, this is how we do it. So, it is not normal and it is actually high pressure, which is registering falsely low. So, you under a false sense of security. So, remember, those of you who have thinner corneas, like me, I also have thin corneas, remember, the pressure is always measured falsely low, and you have to be careful that you don't be under this false assumption the pressure is normal. Actually, it is higher. Okay? So, thin CCT, color racism. What is that? Color racism means the black population of the world. That is, the people who are from Africa, from Caribbeans, the West Indians, they have the highest open angle glaucoma. So, glaucoma is ethnic and racial. So, if you belong to the black population, which we call as colored races, so people from Africa, from West Indies, from West Africa, they have the highest chance of open angle. So, you have to watch out for that. Okay? Being a part of the pigmented races of the world automatically puts you at risk of developing open angle glaucoma more than the other races. And myopia. People who are myopics, they have more open angle glaucoma. So, myopics amongst you, kindly watch out. These are four main risk factors. And what happens here, the trabecular meshwork gets blocked. For reasons of unknown to us, the trabecular meshwork, which is full of small tumor holes, they get blocked with age. So, as these, myopic people turn 50, 45, 50, and they are blacks, colored races, family history, and ethnicity, for reasons unknown to us, the trabecular meshwork develops fibrosis and the aqueous cannot get out. The aqueous cannot get out, the pressure rises, they develop open angle glaucoma. Okay? And what are the signs of open angle glaucoma? You can see the increased cup disc. Look at that. This is pale disc, increased cup disc ratio, splinter hemorrhages, focal notching, and disc asymmetry. So, when you look at the optic disc, these are some of the optic disc signs where increased discs. Now, this is the most important sign, increased cup disc ratio. The normal cup disc ratio is between 0.3 to 0.6. Okay, this is normal cup disc ratio. And anybody more than 0.7, more than 0.6 is 0.7, 0.8, 0.9 is suspect of developing glaucoma. Disc pallor, you can see the pale disc here that you can see in this picture here. This is a sign of glaucoma. The normal optic disc has a healthy reddish orange color. Reddish orange color, this is a pale disc, and that's the sign of glaucoma. Splinter hemorrhage means on the rim of the disc, you will have a hemorrhage like this. These are small lines of hemorrhage. They're called splinter hemorrhage, and this is a sign of glaucoma. And focal notching, you get a notch in the cup, the sign of glaucoma. And disc asymmetry. Asymmetry means the two discs don't look alike; they look separate. Okay, so these are some of the important optic signs of glaucoma. Here, I would be happy with increased cup disc ratio, disc pallor, splinter hemorrhage. Okay, these are the three most important signs of glaucoma. And what about the visual field changes? Remember, the visual field changes that are occurring, the visual field slowly decreases, are occurring because of the optic nerve damage. And why is the optic nerve damage? Because of the raised intraocular pressure. So, what are the visual fields? The visual fields are very famously asked because that is called a paracentral scotoma. The scotoma is a localized loss of vision surrounded by normal vision. Remember, scotoma is not blindness. Okay? Like, for instance, look at this visual. This is my visual field. No? So, in this visual area, there is an area somewhere here where I cannot see. This is called a blind spot. So, the blind spot is an example of a scotoma. Remember, scotoma is defined as a localized loss of vision surrounded by normal vision. Remember, that it is not blindness. It's a very small area of loss of vision of the patient. It's a localized loss of vision. These are called scotomas, and close to the center means paracentral scotoma. Okay, so this is the earliest field defect of glaucoma number. Close to the center, there is a localized loss of vision called a paracentral scotoma. This is the earliest sign. You can have a Bierum scotoma. What is that? Look at that. It's called a Bierum. J becomes silent. It becomes Bierum. And see, this is an extension of the blind spot in the shape of an arc like that. Okay, it's an extension of the blind spot in the shape of an arc. This is called a Bierum scotoma. This is a very powerful sign of glaucoma, and anybody of you who has Bierums would have glaucoma. Okay, a nasal step. Okay, a nasal step means on the temporal side is the blind spot. On the nasal side, there is a step-like field defect. The field defect begins like this. No, it looks like a step. I have put a foot on it like this. This is a step-like field defect, and this is a nasal step. Again, nasal step, remember, is very characteristic of glaucoma. So if you either get a Bierums or a nasal step, it means you are heading towards glaucoma. And you have an arcuate scotoma. What is that? It's an arc-shaped scotoma like this. An arc-shaped scotoma like this. So remember, these are the 4 important field defects of glaucoma that we like to ask you about glaucoma. And for this, we have to do visual field testing, which means a perimetry. So on the perimetry, if I detect any of these 4, either paracentral scotoma or a Bierum scotoma or an arcuate scotoma or a nasal step, I would think you're developing glaucoma. Okay? But the most characteristic, what is the Bierums and the nasal step. Okay? And can you have visual field defects in any other condition of ophthalmology? Yes, of course. Remember, visual field damage is a optic nerve, is a sign of optic nerve damage. So any time your optic nerve gets damaged, be it glaucoma, be it neuroophthalmic conditions like optic neuritis or papilledema or retrobulbar neuritis or traumatic optic neuropathy, any time the optic nerve gets damaged, you will have visual field defects. Okay, but glaucoma is one of those visual field defects causes, and there are very specific field defects of glaucoma, which we just talked about: the paracentral, the Bierums, the nasal step, and the arcuate scotoma. Okay, various other conditions have various other field defects. Okay, they are not typical of glaucoma. And the only symptom of glaucoma, remember, open angle glaucoma at least, because it's completely silent, there is no pain, no redness, no loss of vision, no corneal edema, no colored halos, nothing. The only symptom is a frequent change of reading glasses. Remember these are older people, 45 and 50. So we all know that older people, 45, 50, they need reading glasses. Here, if you look at your parents' reading glasses, normally they change every 3 to 4 years. But in glaucoma, they will change it every 6 months or 1 year. Typically, the patient will complain to you of glaucoma and complain to you, look doctor, I'm not able to read with my glasses. I'll say, I have just changed it last month or last year. He says, but I can't see. Remember, this frequent change of reading glasses is the only sign of open angle glaucoma. Why is it changing? Because the raised intraocular pressure is destroying the ciliary muscle. The ciliary muscle is a very sensitive muscle, is destroyed. It cannot cause accommodation, it cannot accommodate. The patient keeps fussing about with his glasses and can't read. So please remember, if you have older relatives like your parents, your grandparents, okay, and others, parents, grandparents and others, they are older parents, because these, remember, the old patients, they complain to you, look, my reading glasses are changing very fast. Remember, they could be heading into open angle glaucoma. Okay? This is the only symptom. So, the problem about open angle is that it's completely silent. There's no pain, no redness, no watering, no irritation, no headaches, no colored halos, no nothing. Slowly, 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 you have tubular vision. The end stage lands up with tubular vision or tunnel vision. Okay? So this is the problem of open. What about angle closure glaucoma? In angle closure glaucoma, let's look, the angle, it's a different thing. Here the angle gets closed. Okay, look at that. This was the original angle. In open angle, if you saw, this was the trabecular meshwork here, which was getting blocked, no? Because they were fibrosed and not allowing the aqueous to get out, so the pressure rose. But in angle closure glaucoma, the angle is not open, it is closed. Okay, so it closes like this. If you look at this, this is the angle. And why should it close? Let's talk about why should the angle close. And before we talk about why should it close, we need to talk about the risk factors of angle closure. What's risk factor? Again, remember, these are middle-aged, just like open angle, they are also middle. So it means usually above 50. And these are mostly females. Why females? Remember, open angle glaucoma anybody can have, males or females. But angle closure glaucoma only occurs in females, because not only, but more, say about 60%. That is because the female eyes are smaller. You all know female eyes are slightly smaller than males, so the angle is also shallower and the anterior chamber is also shallower. So it's easier for the female eyeball angle to close because it's already shallow to begin with. And they are hypermetropes, that means they have small eyes. Hypermetropics occur to people with small eyes. So again, they have a small eye and the angle is shallower, it closes easier. Hypermetropes. Shallow anterior chamber we've talked about, and Asians. Why Asians? Remember, all of us, Asians, Indians, Pakistanis, Sri Lankans, Nepalese, everybody, all Asians, Chinese, Japanese, Mongols, we have slightly shallower eyes compared to European eyes. So because we have small eyes, they see shallow and the angles close easily. So these are some risk factors, and the most important risk factor, but this is the mechanism, it causes pupillary block. See what happens. The pupillary block occurs, one particular thing caused by the pupil blocks when there is mid dilation of the pupil. Remember that when the pupil dilates halfway, okay? The normal pupil is about 3 to 4 millimeters, and this pupil would go to halfway. It is 5 to 6 millimeters, that's called mid dilatation. So look at this. This is the normal antechamber. This is the angle, and you know the aqueous humor. It comes like this from here. See, it flows here into the posterior chamber, through the pupil, into the anterior chamber, goes to the angle, and goes out like this. Okay, this is a normal pathway. But now, see angle. What happens? What happens is the pupil dilates midway. I just told you mid dilation, so it dilates like this. See what happens. When you look at my finger, in order for the pupil to dilate, originally is like this. In order for it to dilate, iris has to relax, is not? The iris has to relax. Iris is normally a tight and a very, very tight and a contracted structure. But in order to dilate the pupil, it has to relax like this, not? It has to relax, and this relaxed iris becomes loose and lax and flabby. Loose and lax and flabby. Look at what happens to the iris. Look at what happens to the iris. And this relaxed iris is like this. See what happens? It falls back like this onto the lens, because it's loose and lax, so it doesn't have any rigidity in it, and this loose and lax iris, see, it tends to fall back on the iris like this. And now see what has happened. All the aqueous humor which was here, the pupil is blocked here, no? The lens is blocking the pupil. You can see the pupils get blocked. So all the aqueous humor gets trapped in the posterior chamber. It pushes the iris forward, and the iris angle closes, okay, because of the trapped aqueous. So that is the reason. So main thing is the pupillary block. Okay. Why does the pupil block? Because of mid dilate. Why does the pupil mid dilate? Well, it could be anything, because it could be drugs like atropine, homotropine, cyclopentyl, tropicamide, which are all dilators, or it could be night, when the pupil dilates at night time, okay. So various conditions cause mid dilatation, and if this mid dilation occurs in elderly, female, hypermetropic Asian females, then it's already shallow and it may cause pupillary block, okay. So there are 4-5 stages of angle closure glaucoma. The latent, which is mostly hidden, you can't detect it. Subacute sometimes occurs. Patient has these colored rings coming at the end of the day when he's tired. Sometimes these colored rings, which becomes normal. But the most dangerous and the most sudden and the most dramatic is the acute angle closure glaucoma, where the patient comes to us with full severe attack, raised intraocular pressure, pain, redness, loss of vision, colored halos. It's a full panic, and this may lose vision. This acute angle closure glaucoma, remember the hallmark of it is a severe pain, and it does not go back itself. Subacute, they go back itself. The spontaneously resolve. Acute angle closure glaucoma, the spontaneously do not resolve. We have to admit them and lower the intraocular pressure, otherwise the patient will become blind within 5 days, okay. Then chronic and absolute. So these are the 5 stage angle closure. We only talk about acute angle closure glaucoma because this is the most dramatic and causes the maximum problems for us. So the patient presented with, you can say, a sudden severe pain, redness, blurring of vision, and colored halos, okay. So again, angle closure glaucoma, remember, has colored halos just like cataracts, but the reasons are different. So in cataracts, there's also colored halos. Angle closure glaucoma is colored halos. The difference in this mechanism is different, because in angle closure glaucoma, the colored halos occurs because of corneal edema. Okay, you understand? Because the pressure is so high. See what happens. The pressure of the glaucoma is so high. What it does, it forces the aqueous into the cornea, and this aqueous enters the cornea and causes corneal edema. Corneal edema is droplets of fluid, and look at these fluid droplets. They behave as optical prisms. Which means they split the light in the colors of the rainbow like this, and they split the colors of the light. Like this is what the optical prism behaves like, no? It splits the light like the colors of a rainbow, And that is why these patients also have colored halos. So remember, the difference is in cataracts, the colored halos occurs because of different refractive indices of the cataract, but in angle closure glaucoma occurs because of the prismatic effect of the condyloma. Okay, so there are different mechanisms, but the color halos are the same. And so sudden severe pain, raised intraocular pressure, eyes for red and vomiting, and patient is severe pain, crying and shrieking and shouting. And on examination, the patient is very famously vertically oval, mid-dilated, and non-reaculate. See, normal pupil is circular like this, is not. But in angle closure glaucoma, acute angle closure, look at that, it becomes vertically oval, which you can see the diagram here, mid-dilated, it's half dilated because that's when the attack takes place, and it's red and not reaculate. Remember, the most basic reaction of the pupil is that when you flash a light, it constricts. You take it away, it dilates. This most basic reaction, it does not take place anymore and it stops reacting. So this is a very powerful pupil which we describe as vertically oval, mid-dilated, and non-reacting to light. Okay, so this is the classic feature of angle closure glaucoma. And remember that sometimes we'll ask that again a neat PG MCQ, how to differentiate chronic angle closure glaucoma from open angle. Remember, acute is very symptomatic, but chronic, the pressure is already high, there's no pain, no redness, no watering, no loss of vision. So chronic angle closure looks very much like open angle in its lack of symptoms. Okay, and the only way to differentiate between them is to do gonioscopy. Remember, look at the angle. We have to differentiate because you look at the angle by doing this thing called gonioscopy. Remember, gonio means angle. So just do gonioscopy. In angle closure glaucoma, you'll have a closed angle, open angle, the angle will be open. It's visible. So gonioscopy differentiates between open angle and angle closure glaucoma because they look similar. And one more powerful test is the Fincham's test. Fincham's test is to differentiate between the colored halos of cataract glaucoma. Remember, I just told you they have different causes. So where we do, remember, you give them a stenopixel. Look at that. What is this? Stenopixel slit is this one. It's a plastic disc, completely opaque, with a central slit down the center. Okay, you can see the slit here. You give this to the patient and ask the patient to move the slit in front of the eye like that. Okay, remember, you can't see the colored halo, only the patient can see it. This test is to be done while the patient is seeing the colored halo. So if you see the colored halo like this, you give the slit to her and ask this to move in front of the eye like this, and ask her, because mostly it's a female patient, what is happening to the colored halo. If the colored halo breaks up, like this, see, this is the colored halo like this, no? It breaks up like this and unites, breaks and unites, it means it's a cataract. And if it does not break up, it is glaucoma. So very powerful test. Remember, in angle closure glaucoma, the colored halo will not split up in Fincham's test, but in cataract, it will split up. So that's a very powerful test to differentiate between colors of cataract glaucoma, right? And so now we have diagnosed open angle, angle closure. Remember, they are different, totally different angles. Open angle, there is no pain, redness, loss of vision, colored halos, etc. Acute angle closure glaucoma has severe pain, redness, vomiting, loss of vision, colored halos, condyloma, etc. They're totally different. So once you've diagnosed glaucoma, what is treatment of glaucoma? The treatment of diagnosed glaucoma is to lower intraocular pressure. Remember, that's the only thing, because the visual fields cannot be changed, they cannot reverse the visual field damage, and the optic disc damage cannot be reversed. They will remain the same. But at least you can lower the pressure, so further optic nerve damage is avoided. Okay, so further optic nerve damage is avoided. So this is the treatment of glaucoma. Just lower the IOP, and they are irreversible. So how do you reverse lower the pressure? The best ways are to use drugs. Remember, open angle glaucoma, it will lower the pressure. How do you lower the pressure? There are two ways. Either you increase the outflow of aqueous, so the pressure falls down, or you decrease the production of aqueous, so the pressure falls down. Is it not? So remember, when we increase the outflow of pressure, there are two groups of drugs. What are these? They are called cholinergic agonists. Cholinergic agonists would increase the outflow of aqueous, and they are drugs like pilocarpine and carbachol. They increase the outflow of aqueous through the trabecular meshwork. That is one group. The second group of drugs to increase the outflow are called the prostaglandin analogs, PGAs. The prostaglandin analogs, they use this pathway which is called the uveoscleral pathway. Remember, normally this uveoscleral pathway only contributes to 20% of the aqueous drainage. Okay, the trabecular meshwork is the one that contributes to 80% of the outflow. So this uses a different pathway called uveoscleral, And the prostaglandin analogs like latanoprost and pimatoprost increase the outflow through the uveitis axis. So remember, both these drugs increase the outflow, lower the pressure, but the pathways are different. Okay, pathways are different. The pilocarpine carbachol increases the trabecular meshock pathway. The prostaglandin uses in the uveitis pathway. Be careful about that. The rest of all the drugs decrease the suppressed production. They suppress aqueous production, so the pressure comes down. So there are different mechanisms. Okay. And remember, so a few MCQs about the open-angle glaucoma drugs. Remember, drugs of glaucoma are important. Drugs of glaucoma, we have the drug of choice of POGs. Remember, POG stands for primary open-angle glaucoma. We call it primary because, as I said, we don't know the causes. Okay. So this is the same thing as open-angle glaucoma only. We could just call it primary open-angle glaucoma, POG. This is worldwide. Remember, the most common type of glaucoma are open-angle glaucoma. You know. Drug of choice is prostaglandin analogs. Kindly remember, FDA has mandated that the drugs of choice are the prostaglandin analogs. So latanoprost, pimatoprost, tavoprost. Why these are drugs of choice? Because they're very, very safe. Okay. Remember, there are hardly any systemic side effects. There are some topical side effects, but systemic sides are very rare. So this is the drug of choice, open angle. Okay. So please remember, they are the safest drugs of glaucoma. They are also, prostaglandins also, remember, are also the drug of choice of normal tension glaucoma. Remember, normal tension glaucoma is difficult. No, why? Because the pressure is all normal. Suppose you have pressure is 15. Now it is easy for a drug to lower elevated pressure 25, 35, 45. But it's not easy for a drug to reduce 15, 16 because they're already physiologically normal. It's not. Already the pressure is normal. You want to reduce them further. From 15, you want to get down to 10 or 11 or 12. How do you do that? So the drug has to work harder. Remember, prostaglandin drugs are also the drugs of choice with normal tension glaucoma. So be careful about that. So they are two important drugs. And angle closure glaucoma, remember, mostly are not drugs. We use surgery. Why? Because angle closure glaucoma is already closed. The angle is already closed. Angle is already closed. So how will the aqueous get out? They won't be able to get out. So that's why mostly we use surgery. And the surgery is called LI, laser iridotomy. Okay, what is that? You make a small hole. You make a small hole in the periphery of the iris like that. Okay, so this behaves like another pupil because remember this pupil block, angle closure glaucoma is called pupillary block. This pupil is already blocked, so we create another small pupil through which the aqueous can drain out like that. Okay, so LI called laser iridotomy, which is used by our old friend. Which laser is it? Our old friend, the Nd:YAG laser. The Nd:YAG laser is the laser of choice. Okay, so Nd:YAG laser, we make a small hole, blast a small hole in it, and it allows the aqueous to get out. So this is the treatment of choice of angle closure glaucoma. Okay. Now the latest drugs. So remember, we have this questions from pharma and ophtha where we often ask latest drugs. Remember, the latest drugs of choice, latest drugs in glaucoma introduced are fairly recent. We call them the ROCK inhibitors. Okay, ROCK, it stands for Rho kinase inhibitors. So often we call them ROCK inhibitors just to make it sounding like a rock star. Okay. So Rho kinase or ROCK inhibitors we call them. Remember, these drugs we have to remember, these are netazodyl and ripazodyl. Just remember, you'll probably do in pharma also, but just to tell you, the latest drugs introduced in glaucoma are netazodyl and ripazodyl, which are Rho kinase inhibitors, and they also increase the outflow. They also decrease production by increasing the outflow of the aqueous humor. Right. Then anti-glaucoma drugs. Some other drugs, question anti-glaucoma drugs are, what about drugs of choice in children? Remember, these anti-glaucoma drugs are extremely toxic, so we try to avoid them in children. So the drugs of choice in children are the safest anti-glaucoma drugs are topical carbonic anhydrase inhibitors. CAIs are topical carbonic anhydrase. These are the drugs of choice in children because they're the safest anti-glaucoma drugs. Okay, so dorzolamide and brinzolamide can be used in children. Okay. Even the prostaglandin analogs are not very safe in children, so we have to restrict ourselves to dorzolamide and brinzolamide. Remember, a very important MCQ is what anti-glaucoma drug is contraindicated in children. Okay, what anti-glaucoma drug is contraindicated in children? Remember, it is brimonidine. This is alpha-2 agonist, which is contraindicated in children because it may cause respiratory apnea and death. Okay, kindly remember, it can cause respiratory apnea. It may cause death also. Very important MCQ, which anti-glaucoma drug is contraindicated in children? Okay, that is brimonidine. Then another powerful question is, which anti-glaucoma drug is contraindicated in pregnancy? Remember, these are the prostaglandin analogs. Why? Because remember, these are prostaglandin analogs. So if you give it in pregnancy, it may cause cervical dilatation and may cause premature delivery. Very important to remember. And prostaglandin analogs, though the drugs of choice in glaucoma, are not to be prescribed in pregnancy because they might cause premature delivery. Okay. So what are the drugs of choice in pregnancy? Remember, actually in pregnancy, none of the drugs are very safe, but in the first trimester at least, remember, in the first trimester at least, brimonidine is a drug of choice. So be careful. It is a drug of choice in pregnancy, but also it is contraindicated in children. Be careful. So while the child is in utero, you can give the drug to the mother, but when he comes out, then you can't give it to him. Be careful about that, please. Okay, they are different people. So drugs of choice in pregnancy is brimonidine in the first trimester, but is contraindicated in children because of respiratory apnea. Then remember, bronchial asthma, beta blockers are contraindicated. Beta blockers like timolol, levobunolol, they will cause bronchoconstriction and cause bronchial asthma. Absolutely contraindicated. And diabetic patients, we will not give glycerol, because glycerol raises the blood sugar and worsens diabetes. And acetazolamide will cause ketoacidosis. Okay, it may cause ketoacidosis because it causes metabolic acidosis. By excretion of potassium, it leads to metabolic acidosis. So we have to use it in caution. You can give it, but you have to give some potassium supplements. Okay, and very important, remember, brimonidine has very important side effect, depression. Please be careful. Remember, depression, according to WHO, is the world's most common prevalent disorder. And many of you sitting here are subclinically depressed. You know, looking at me with baleful eyes like that, I can make out that you're deeply depressed. Okay, but not me, not me. So remember, watch out for depression. Brimonidine is to be contraindicated in depression. Okay, another drug which can cause depression is timolol, but it is not so much. It's not so much. It's brimonidine which is mostly. Brimonidine actually a lot of MCQs. It's contraindicated in children, contraindicated in depression. It is a drug of choice in pregnancy. So multiple choices, MCQs you can have in brimonidine. Okay. Then the next thing of the anti-glaucoma drugs is apraclonidine, which is another alpha-2 agonist, along with brimonidine, has the highest amount of allergic reactions. Okay, so people who have allergic reactions, we avoid them. In any case, remember, apraclonidine is not a drug which is very commonly used nowadays because of multiple reasons. But remember, brimonidine is also in the same group. So brimonidine is also highly allergic. Okay, because any two alpha agonists are highly allergic drugs. So apraclonidine and brimonidine are to be avoided in people who are allergic patients. Okay, and the next is brimonidine, as I said, because these are also belong to the alpha-2 agonists. And topical CIs, common analgesics like brimonidine and brimonidine, they can, and sorry, not brown, sorry, it's dorzolamide and brinzolamide. They are topical CIs. They can also cause allergies, and prostaglandin is the third. So this is the highest of allergies. First, the alpha-2 agonists, then the topical CIs, then the prostaglandin analogs. And another question, which brimonidine and pilocarpine, which we'll discuss again when we do conjunctiva, are drugs well known to cause follicles. What are follicles? Follicles are rounded conjunctival elevations, or rounded collections of lymphocytes in the conjunctiva, which are seen in conjunctival infections, particularly viral and chlamydial. Viral and chlamydia, they are collections of lymphocytes which are seen in certain infective disorders, particularly viral and chlamydia, but can also be seen in certain drugs like brimonidine and pilocarpine. They are well known. See, these are all PYQs. Okay, pretty young, not pretty young things, but pretty frequently asked questions. Okay, so PYQs, previously asked questions. And then what about the fastest angular closure glaucoma? Remember anti-glaucoma drug? We have to remember this. This is mannitol followed by acetazolamide. Why? Because mannitol and acetazolamide are the only two drugs which can be given as IV intravenous. So they act fastest. In India, we only have IV mannitol available. Acetazolamide is not yet available. So given a choice, the fastest anti-glaucoma drug is mannitol. Which will lower the pressure in 30 minutes. Remember, it's intravenous. So this is also the drug of choice of acute angle closure glaucoma. Okay, and I think, my gentlemen, I did say that we will pause. We'll finish by around 9, and I think I've exceeded my time. So the rest of it will start tomorrow at 11 o'clock, but I'll just take a minute to answer your questions which I have missed through, and then we'll wind up here. We will start tomorrow at 11 o'clock, you know, unless, but I'll give me 5 minutes to answer your questions which is here. So we will start tomorrow from tomorrow morning around 11 o'clock. It will be around 5-6 hours, so we expect the class to finish, say, around about 5 o'clock. Okay. Let's hope we finish it faster because you get tired, I know. But maximum should not be more than 5 or 6, okay? So we'll start tomorrow from this glaucoma. But let me just go through your questions and see if there is some questions which you need to answer. And let me see where with that. Let us see this. Well, we have some people quarreling here. It seems that some of you don't like my style. Well, too bad, my friend. I'm so sorry about it. I'm so sorry you don't like me. But the others seem to like me, so I'm here. Of course, you could always come replace me here. My friend here who doesn't like me. I mean, if you don't like me, why don't you come and replace me here? Okay, I'm so sorry about it. I don't want to argue about it, but there seems to be here. And let's talk about the questions that we have. Yes, does visual field collapse only indicate glaucoma? No. As I said, remember, visual field restriction means there is some damage to the optic nerve. Okay, it could be glaucoma, it could be optic nerve disorders like neuro-ophthalmic disorders like optic neuritis, retrovalvulinitis, papilledema. Visual field loss, visual collapse just means there is some trauma to the optic nerve, some damage to the optic nerve. It could be glaucoma, it could be something else also, okay, like that. Okay? Then that is the first question. Then corneoscopy, my friend Prem Kishore, it's not corneoscopy, it is gonioscopy. Okay, corneoscopy we don't see the cornea. Remember, scopy means vision and gonio means angle. So when you want to look at the angle, remember anything that measures the gonio, anything that gonio mentioned means angle. So gonioscopy means looking at the angle. Goniotomy means making a hole in the angle. Okay, gonio refers to angle. Okay, and we have. Yes, that's what we have. So, my friends, tomorrow we will also include this. Remember, you get your annotated PDF tomorrow after you finish the class in Dr. Bhanu's Telegram channel. You get the annotated version. You're getting it right now. And so, thank you very much, ladies and gentlemen, for joining me. We must express gratitude to Dr. Bhanu's YouTube channel, which has done stellar service. I can't tell you how many students have been telling me they've been waiting for all the subjects to be covered here. So, please watch us tomorrow. Thank you very much. Good night. Sweet dreams.